So I'd like to welcome you all to this joint WHO and UNICEF Global Expert Consultation on a generic model for inpatient care for small or sick newborns. My name is Rajiv Behel. I am the head of the newborn unit in WHO, and I would like to quickly say the team that planned this consultation includes Dr. Gagan Gupta from UNICEF, Dr. Teshome Desta, and Dr. Karen Edmond from WHO, Dr. Lily Carr from USAID, and Dr. Hema Mage from Bill and Melinda Gates Foundation. We are here today, as I said, we will have a very big group for this very important meeting on sick or small newborn care. And when we mean sick or small, we mean babies who are low birth weight, preterm, or have any illness, even if they are not small or preterm. We are going to have interpretation in English, French, Portuguese, Spanish, and Arabic. If you have just joined us, please make sure that you click the globe icon, which is just next to reactions. It's in between pause, stop recording and reactions in the bar below the screen where you see the slide. If you click on the globe, you can choose the language which you want to hear in the presentation or in the questions or the comments that you will hear will be in that language. So I would like to ask my colleague, Teshome, to introduce the objectives of this meeting and also make a few housekeeping announcements. Teshome, go ahead.
Thank you very much, Rajiv. Thank you so much. Since this is a large meeting, we may not have the time to do individual introduction, but we would like to recognize the country delegations that have been invited to this meeting. And your greetings can be done through the chat box. And I just want to repeat again, please rename your profile. Just click on the participant icon, and then you will see more. When you hover over more, then it will give you the chance to rename. Please write your country before your name so that it will be easy to recognize you by country, and this makes life very easy to plan for tomorrow's group work, country group work. So this is an important aspect. I would like also to remind you to remain mute unless you are given the floor to speak. And as I said, this is a large meeting, so please feel free to post your questions, contributions in the chat box. Whenever we have time, we'll entertain questions. We'll give the floor to selected individuals. But the chat box will be the main means of getting your questions, your contributions, suggestions, and so on. Next, please. Yes. So the purpose of this meeting is really to arrive at a consensus on core elements of the generic model for the inpatient care of small or sick newborn at the district level. And this is in line with the ENAP target 4 of 80% of districts having at least one functional level 2 inpatient newborn care with respiratory support, including CPAP. Next. So the main objectives of this meeting is really to share country experiences of scaling up inpatient units for sick or small newborn care, we have noted a number of countries have really advanced in scaling up special care units, and this is a great opportunity to learn from them. And the second objective is really to build consensus on the key elements of a generic model for scaling up quality inpatient, small or sick newborn care that can be adapted to the country context and aligned with the WHO Global standards for improving the care for small or sick newborn. Next. So as I have said, we have invited the ENAP priority countries or focus countries based on the burden of disease. So 36 of these countries are the ENAP priority countries, but we have invited 4 more countries to share their experience because they have a lot of experience in the last couple of years or a decade or so. We have also invited partners. These are not all, but you will see later on, and we'll also share once we get confirmation of their participation, a consolidated list of participants. But our UN partners, UNFPA, UNICEF are here with us, and our development partners, USAID, the Momentum countries, BMJF, and Save the Children, PAS, the PIGO, IPA, and other professional associations, and also ICM, COIN, country and regional level associations and other partners are invited. Like I said, we will share a consolidated list after confirmation of participation. Thank you. Back to you, Rajiv. Thank you very much.
Thank you very much, Teshome. So the goal here, as you've seen, is that we have spoken a lot in the past decades about improving newborn survival and newborn health. We have worked on home-based care. We have worked on essential newborn care. And the time is now right for almost all countries to really go towards scaling up of also, in addition to what we have been doing, not to replace what we have been doing, to really add inpatient care and improve the care of the sick and small newborns at inpatient level by having every hospital at least district level have a newborn care unit. Now that's a huge ask, and we are all trying here to see if this can be made possible through sharing of experiences from countries that have made progress in this, and also to understand from specific projects and programs what are the components that should be key to do this. The idea is to have something which all of us can go get behind and actually implement together. And this set of partners that you see here, I'm so glad to see that it is such a huge list. Next slide, please. I think we are going to now just tell you a little bit about the agenda for the 3 days. This is session 1. It is just an introduction. I'm now going to ask my colleagues from UNICEF, USAID, and WHO to make opening remarks. But after that, we are going to go, today is going to focus mostly on country presentations from these 7 countries that you see. Tomorrow, we are continuing the country presentations, but we will have
thank you, Gagan. Thank you.
Yeah, now this is what we need to keep our microphones mute, and I'm going to request her or Olive to please help in case people forget. So we will be talking about these experiences, and we will have group working sessions on this. But then we are going to talk about the 3rd day. We are going to go into, if you go to day 3, please. Day 3 will focus on like specific important innovations that we are collecting evidence on and which are extremely important as we go along. Things like innovative technologies, lactation management, maternal well-being, developmentally supportive care, etc. In the final session on day 3, we will pull all this together and then go towards trying to see how we want to move forward for global scale-up of sick and small newborn care in inpatient facilities. So day 1, mostly focusing on sharing country experiences, continued on day 2 with some synthesis of those country experiences, but also group work sessions. And then on day 3, we are talking about specific topics and eventually we'll bring things together. So I would really encourage all participants to join on all the 3 days. Next, please. So I'll call on Dr. Kim Dixon, Chief of Maternal, Newborn and Adolescent Health at UNICEF headquarters, to make a few opening remarks. Kim, over to you.
Thank you, Rajiv. I take it you can all hear me very well.
Yes.
Okay, so thank you so much. I'm really delighted to be part of this conversation. And I'm also very impressed to see the number of people that have joined. I hope this will continue for the full 3 days of the workshop. UNICEF is delighted to be part of this, and we will be making country presentations as well, showing you that we also have the ability for on-the-ground implementation of the small and sick newborn care. As we all know, the COVID-19 pandemic continues unabated, and in the meantime, 63 countries still remain off track to meet the SDG target for neonatal mortality. And therefore, we have our task cut out as a newborn community. We need to work to preserve and protect the gains of the last decade for newborn survival. Today and over the next 2 days, we are going to really work on a set of actions and agree on a pathway for scaling up one critical pillar, that is the district level coverage of small and sick newborn care that has the potential to save about 747,000 newborn lives annually, and also reduce preventable newborn deaths by nearly half. Nearly 30 million newborns globally need some form of inpatient care at birth each year. And as institutional deliveries are increasing, there's a simultaneous need to invest in facility-based care for newborns. Getting the inpatient care right is not only critical to significantly impact neonatal deaths, but also is critical to reduce the burden of long-term disability. This thinking led to adding a specific target under ENAP for achieving 80% coverage for care of small and sick newborns at district level. Failing to invest in facility-based newborn care with strong follow-up systems will not give us full benefits of institutional delivery for newborn survival, especially for those who are born too soon or too small. As countries are looking for guidance and resources for implementation of the ENAP Target 4, this scale up of care for small and sick newborns, this consultation and emerging guidance thereafter will help program managers to have a better understanding of the pathways to scale up and the critical steps needed for implementation on the ground. The scaling up efforts will need to follow a health systems approach, ensuring the right policy framework, a strong government leadership, adequate financing and human resources, along with needed infrastructure and equipment to provide such care, backed up with a strong data system. This is really feasible in resource-limited settings, as you hear successful presentations from countries that have been successful in doing this, such as in India, Bangladesh, and Sierra Leone, and you hear many others that have managed to do this. And we are really looking forward to many other countries joining this. I really hope that we'll benefit from the 3 days of exchange of information. And let me assure you that we at UNICEF remain committed to push both policy and program actions globally and also locally on the ground so that we can bend the curve on newborn mortality and accelerate efforts to scale up newborn care for all. I really wish to congratulate all of us for the progress made so far, and I look forward to working with all of you as we continue. Thank you very much, and thanks for giving me the opportunity. Back to you, Rajiv.
Thank you very much, Kim. I would like to call on Dr. Lily Carr from USAID, who is the Newborn Health Team Lead in USAID, to also make a few opening remarks. Thank you. Over to you, Lily.
Thanks, Rajiv. This is really a wonderful moment for me to be here at this meeting, and thank you for giving me the opportunity to say a few words to welcome over 200 people. It's wonderful to see all of you. To me, this meeting is very exciting because it marks a watershed in the field of global newborn health. Why do I call it a watershed moment? Because it marks a transition point in the journey of newborn health, where we're shifting gears from 20 years of a broad public health approach of preventive and promotive messages to a more targeted approach to reach the most vulnerable newborns. Those are the small and sick ones. And they are the ones who are most likely to die. And if they do survive, they're the ones who are most likely to suffer from disabilities or developmental delays. So this is why I think it's very, very significant, and it is a watershed moment in my mind. So why is this transition significant? You know, we, as Kim said, you know, we have done well in that the newborn mortality trend has gone down in the right direction. And we are now globally at 18, NMR of 18 per 1,000 live births now. And our goal is to achieve an SDG target of 12 per 1,000 live births. And as you know, the last few miles are always the hardest. And if you continue to do the same thing, we will not, our trends will just plateau. So we must do something different to avoid plateauing of mortality trends. And this is why this focus on small and sick newborns, I think, is what we are really planning to do differently. In addition to the previous focus on essential newborn care, preventive and promotive messages for all newborns, whether they're born at home or in the facility, we're now adding on this extra, more complex layer of really focusing on the small or the sick babies in level 2 care. And as you know, it's very much like doing C-section. You cannot do C-section without a functional health system. So similarly, you really can't do small and sick newborn care without a functional health system. So at the heart of our approach would be the core elements, which are the systems. And I look forward to hearing from countries on how they have strengthened health systems in order to begin implementing level 2 care. We're also thinking about some new, very exciting new elements, which I believe are not really done at scale, which are things like maternal mental health, developmentally supportive care for the newborn. So I'm really very excited about integrating these new concepts and new elements as part of the core elements of this generic model. And the good thing is that we're not starting from scratch. We have laid the foundational elements. As you know, there was a document called Survive and Thrive, Transforming Care for Every Small and Sick Newborn, where we laid out the rationale for focusing on small and sick newborns. And under WHO's leadership, we have the quality standards for small and sick newborn care. We have a human resource roadmap for small and sick newborns. We have the updated ENAP targets and so on. So we've laid the foundation, and now it is up to us to use those foundational elements to integrate it, put it all together, and actually roll it out in countries. And we know many countries have the experience. We're fortunate they are here. They will share their experience with us. We will learn from them. And then I'm really excited that the outcome of this meeting would be a generic model that countries can look at and adapt as they begin to think about integrating small and sick newborn care and scaling it up in their countries. So I'm really very excited about this meeting. Thank you all for being here, and thank you for this opportunity to say a few words. Thank you.
Thanks very much, Lily, for those thoughts. I'm going to call on Anshu. Anshu, you have to change your name because it looks like you have my name in your profile. We have two Rajiv pairs, which is fine, but maybe you want to change it. Anshu Banerjee is the director of the Department of Maternal, Newborn, Child, Adolescent Health and Aging at WHO Geneva. And a few opening remarks from you, Anshu. Over to you.
Thanks, Rajiv. And I couldn't find the password for the meeting, so that's why we have two Rajivs on the call today. But as you have heard from other speakers, we have, of course, updated targets for the Every Newborn Action Plan, and this includes a new indicator looking for small and sick newborn care, and that is 80% of districts to have at least one functional level 2 inpatient newborn care unit to care for small and sick newborns with respiratory support, including continuous positive airway pressure or CPAP. And so we really wanted to have this indicator A to really push this agenda to district level, to subnational level, in order to be able to also strengthen equity at national level, let's say, and not only for these care units, let's say, to be available at the capital level, but really that every district should have them. And so under the ENAP umbrella, WHO and UNICEF, together with other partners, including USAID, are holding these expert consultations to discuss learnings from countries and expert experiences. It's really exciting for all of us to plan, to see how to arrive at a consensus, as Lily was just highlighting, a consensus on core elements of a generic model for inpatient care of small and sick newborns at the district level that can help achieve these ENAP targets. Now, in relation to this, WHO developed already standards of care for improving the quality of care for small or sick newborns in health facilities in 2020. And these standards, of course, will have to guide, let's say, the model that we want to develop. So these standards define, standardize, and mainstream inpatient care of these newborns, building on the essential newborn care platform and ensuring consistency with the WHO quality of care framework. The aim of the standards is to guide countries in caring for this vulnerable population and supporting quality of care of newborns by providing guidance on the requirements for ensuring high quality care in health facilities. WHO has almost completed also updating and developing recommendations for feeding low birth weight and preterm babies, and next year we'll be looking at updating and developing recommendations for neonatal sepsis and for resuscitation, neonatal resuscitation. And so these recommendations are going to be based on the highest quality of evidence and inputs from the highest levels of expertise. But already we need to anticipate a little bit, I think, what those recommendations are going to be, so that the model that we're going to develop will be able to address those recommendations as well. To support countries to implement the recommendations and quality standards and to achieve new targets for small and sick newborn care, an important step is therefore to develop this model of inpatient care together with an implementation guide so that countries know how to put it and set it up, put it in place and set it up. So this meeting really comes at the right time to build consensus on the core elements of a model of inpatient care for newborns, to implement the recommendations and standards, and to ensure that they can be scaled up at district level to all districts in every country, which is an important pivot point, as Lily actually also just highlighted, for all this, for both Ministries of Health and partners. So I look forward to the meeting of the next few days, and just to highlight also that the stage recently had deliberations on KMC, and there will be a number of recommendations that really also apply to this model on how we can do that for a maternal newborn care unit, as well as around PSBI, and also how to make sure that these units can address those kind of issues. So Rajiv is leading this work together with stage members and other partners to really see how we can implement this. And I think this model that we'll be discussing over the next few days is going to be crucial also to take those pieces of work forward. Thank you very much, Rajiv.
Thank you. Thank you, Anshu, Lily, and Kim, for those thoughts and for putting the weight of the three organizations, WHO, UNICEF, and USAID, behind this scale-up effort. And so we are going to quickly go into the presentations. I think we are already a few minutes late. I'm going to hand over now to Dr. Gagan Gupta for moderating session 2. Gagan, over to you.
Thanks Rajiv, and thanks everyone. Greetings to all of you from UNICEF headquarters in New York. From global advocacy and commitment, let's now move to countries where the action lies. And in the first block, we will be looking at the countries from Asia, especially South and East Asia. And these two regions are very important given the fact that not only they account for nearly 1 million newborn deaths every year, but these are also the two regions with very good institutional delivery. South Asia with 74% and East Asia with 92%. And a very high share of neonatal to under 5 deaths, with South Asia having more than 60% under 5 deaths as neonatal. So a combination of high institution delivery and a high share of neonatal to under 5 deaths make these regions perfect to scale up and expedite the inpatient care of newborns, especially the small and sick. So we have India, Bangladesh, and Vietnam in this block, the three countries with nearly a decade of experience in rolling out inpatient care, which will be very relevant for all of us. So I hand it over first to India, and we are privileged to have Dr. Sumita Ghosh, who is the Additional Commissioner in charge for child health, adolescent health, safe abortion services, and the Aspirational District Program of Government of India. She's a pediatrician with more than 35 years of experience, and I had the privilege of working with her closely when I was in India in my role in UNICEF earlier. So over to you, Dr. Sumita Ghosh. We are so excited to listen from the great work India is doing. Thank you. Can we have the slides?
Good morning, good afternoon, good evening to all who are present here today on this web platform all over the country, from outside the country, from New York, from Geneva, and others. I'm very delighted to present the India model, and quite a successful model for inpatient newborn care in LMIC, and the core elements of our India model for sick and or small newborn. So when we talk about India, we talk about when we talk about India, it is talking about 18 to 20% of the world of newborns. So a huge cohort, 26 million births every year. Approximately 18% of them are low birth weight, approximately 13% preterm, and they are managed. Approximately 1.2 million of small and sick newborn is being managed at level 2 care. So it's huge in numbers and how it is being done. So it is a continuum of care. It is an integrated approach starting from early, even pre-conception stage, and also antenatal care. Then emphasis on safe delivery, care during labor and childbirth, immediate newborn care, care of healthy newborn, coming into the care of small and sick newborn, where we will be focusing today, and which is the purpose of this presentation and consultation. And then beyond that, after thriving, the agenda of survival comes.
Dr. Sumita, sorry to interrupt. And Kapil, if you can put it in the full screen mode, I think right now it's not in the full screen mode.
It is actually.
Okay, fine. Okay. No, we have lost the slides now. Yeah, you're back.
Yeah, so it's the newborn care, what is being practiced in India in this model. It is as already said, it is based on institutional delivery, increasing the percentage of it, then immediate essential newborn care and resuscitation to all who need it, to all births. Then the divisions comes, the healthy newborns, they are discharged after 48 hours from the institutions, and they are taken up for home-based newborn care. But when they are small or sick, it goes into facility-based newborn care, which is have been rapidly scaled up in the country. So after this facility-based care, when they are either stabilized, managed, they are ready to be discharged. They are discharged into the community, their homes, but follow-up services continue. And this continuum of care continues, and the whole concept is that not a single sick newborn or small newborn is missed or they are not taken care of. So when we talk about what are the care which all newborn receive, it is the essential care and resuscitation at the delivery points, comprehensive screening for visible birth defects, it is under our RBSK program. The labor rooms quality improvement initiatives have been taken so that they receive the appropriate and adequate attendance of a skilled birth attendance, and then postnatal care already mentioned for 48 hours. Along with that, the birth dose of vaccinations are given. So this is the care that all newborn receive at the facility. Coming to home-based newborn care, it is the healthy newborns as well as the SNCU discharges, facility discharges, they receive 6 home visits for institutional delivery and 7 home visits for home deliveries who have not been attended at birth. So for this, a huge force of peripheral workers, they are known as ASHA, accredited social health activists, and they make these visits to the homes of each newborn, and they are compensated with incentives, and regularly they are supervised and mentored by ASHA facilitators, our community health officers and medical officers and nurses and midwives. The follow-up of care is taken given special importance. Those who have been discharged from SNCU, they are taken up additional visits up to 2 years. They are given special visits. So coming to facility-based newborn care for our newborns who are both healthy as well as who are not so healthy, small and sick. So the system it is a health system approach, and there are approximately 20,000 plus newborn care corners all over the country at delivery points. That is the basic level of care. Coming into the first referral units, we have 2,579 first referral units, that is at the community health blocks and at the FRU level. The first referral units where maternal care first have capacity of blood, emergency, cesarean section. So this is the level 1 care. Here we call it newborn stabilization unit. So these units are vital because they stabilize the not so sick, not so low birth, not so preterm babies, closer at home. They work as first level care, and when the sick and newborn from the second level care are discharged, they can be followed up. It can be acting as a step down unit. So this is the vital area which is being strengthened now. At district level and some sub-district level and also medical college level, we have second level 2 care, that is the special newborn care units, and which is for small and sick babies. They are SNCUs, and they actually constitute the fulcrum of our small and sick newborn care. We have a level 3 care also, that is at the medical college level and in some district level hospitals, that is NICU care, and we have 190 of them. So it is it is a 3-level system, and which is this model is working quite successfully. The missing link is in the community block level, the NBSU, which is being strengthened now, but already we have the structure in place and the capacity building and further strengthening is happening now. I am very happy to say that 85% of all our districts now have a functional SNCU unit, and many districts have actually more than one. And our aspirational districts units, districts which are actually the backward districts for various reasons, geographical reason, the remoteness of those places, the lack of, having HR there, human resources there. So in our priority is having SNCU in all aspirational districts. And out of 112 of them, we have nearly all of them are now having SNCU, excepting few which are, because of very low delivery load or very much, difficulty in reaching there. So we have not yet been able to do, but we are planning by the end of this year. So another important addition, that MCH wings, maternal and child health wings, are coming up in the district level, of which SNCU has become an integral part. The new ones, the new wings are essentially, they are having SNCU as a component of it. Though initially SNCUs were envisaged as 12-bedded unit, but the success of this SNCU, we now have many SNCUs with higher number of beds, 24, 30 beds, and proportionately higher number of, HR posted there. Again, in low delivery districts where the delivery load is really low, we have many SNCUs also having, as low as 5 beds there, but adequate HR. So this at district level has the newborn care services has evolved from the district hospital. There are new physical SNCUs, and the MCH wings have come up. KMC units have been set up, sometimes a separate ward, but mostly integrated with our facility units. And some of the SNCUs are, they are moving into transition with CPAP. We have the district early intervention centers, which are again connected to SNCUs and MCH wings, which work as a referral for the sick and small newborns for their further follow-up, as well as for detecting any developmental delay and managing it at district level only. The LMU lactational management units are there at the district level. So this way, the system is slowly evolving, and we are quite successful with it. And the blank slide, which we have kept for purpose, that is actually having the MNCUs integrated with SNCUs, because the, keeping the mother and child diet intact. So these MNCUs are coming up, and all new SNCUs have now this integrated component of MNCU, mother and neonatal care units together. Along with this, the concept of family participatory care has been introduced in 2017, where the mother or family members, they have been included in active care of the newborn, small and sick newborns, for their survival as well as for development, developmentally stimulating environment. And various audiovisual resources are kept there, so that the staff, they train them, and the mothers and the families, they actually take part in care of newborn, especially kangaroo mother care and other care of the babies. So one of the most major component of our improving quality in this facility-based care for small and sick newborn, this is the capacity building of various level of health workers who are there. At the community level, yes, ASHAs have been trained. At the other in our peripheral health and wellness centers, the ANMs and the community health officers have various packages depending on their duties, their roles, their responsibilities. The training packages have come and they are being trained. Our NBCC, they are being trained into NSSK training, and it has been revised last year. The training has been revised. At the NBSU level, again, as I said, this is being the focus area for strengthening now, where we have introduced training modules for the first time in 2020, and the trainings are happening today only. Regional training has started because of COVID. This gap has been there, but this is in process, and we soon hope that all our 2,500 plus NBSU will be competent as well as confident of taking care of small and sick newborn who can be managed at this level, and stabilizing them, and if necessary, refer them to the level 2 care. Again, district level hospitals, pediatrician training modules are there, specialists and medical officers, nurses, all are being, we have different set of training for them, facility-based training. So that way capacity, we all know the competence at the point of care, the confidence, the providing the precise treatment which is needed for that baby, that is most important. And we are we are actually taking up this very seriously. Talking about human resources, these SNCUs have dedicated HR, and the basic thing is the challenge. The basic challenge is having HR, in all the districts and in adequate numbers, the capacity building of them. These two are most important priorities. Another important initiative has been taken for midwifery-led units, midwifery-based care, and having them trained in neonatology also, for neonatal nursing. And we are thinking of going into neonatal nursing courses also. The challenges of scarcity of specialists, neonatologists, pediatricians, so that is being met with, in difficult areas, that we are offering them flexible packages of remuneration. We are giving a lot of innovative processing of that, so that they are attracted, and actually all our units have the appropriate level of specialists at them. The states, India is a huge country with 36 units of states and union territories. So the states have been given, depending on their local context, they have given flexibility regarding their HR policy reforms, so that they can cope up the necessary challenges. So the whole newborn care system is being undertaken under a health system strengthening approach and for universal health coverage. We have several policies which looks after our Janani Sishu Suraksha Karyakram. They look after up to 1 year of age for any kind of sickness and referral transport, any need for treatment, drugs, diagnostics, that is totally free under this scheme. Under our, the insurance scheme, health insurance scheme, which is called Ayushman Bharat PMJY. So packages have been developed, and they are quite good packages for sick and small newborn. And this is for BPL families and identified families who cannot afford treatment, but they can, with this package insurance coverage, they can even afford treatment at empanel private health facilities. Suman is another important initiative which has been taken, that is Surakshit Matritva Abhiyan. That means safe and assured treatment for safe pregnancy, childbirth, and immediate postpartum care. Special emphasis have been given on grievance redressal and assuring communitization of the process, so that everyone can get involved and they take part and they can improve the system, so that assured services can be given. And talking about free referral transport system, it is being done under universal health coverage and health system strengthening efforts, so that the sick babies, they can be brought to the facilities as well as back to home. This would have not been possible without a proper data management. So we have a very efficient system and dedicated system of SNSU online data collection, and they are all in the portal. And for real-time monitoring, this data is used, and almost 90% of our SNSUs are actually reporting real-time on this platform. And this data analysis is taken by the state as well as the national level, monthly, quarterly. Even NBSU are being attached to this SNC online, so that we have an overall idea what is happening, where the gaps are, and where we should work upon, focus upon. There are regional coordinators, they are placed there in the several regions of India, and they regularly, their responsibility is to monitor the data quality by actually visiting the facilities and see how the data is being entered and how the data is being used by these facilities. More than 4.5 million newborns, including SNCU graduates, they receive home visits, as I said. And whenever there is any developmental delay, they are picked up and they are referred to the health system. The periodic rapid assessment of newborn care units are regularly being undertaken through standardized tools, and it is being used for our action planning after identifying the gaps. So this is regarding the coverage and monitoring. But
thanks, Dr. Sumita, sorry to interrupt. The last 2 minutes, please.
Yeah, I'll finish. Focus is now, after having, after attaining sufficient coverage, the focus is now on quality. For that, we have centers, national centers, collaborating centers at Delhi, and then there are state resources centers. To be precise, 19 of them are placed in the states. They are regularly taking up, providing support for capacity building as well as mentoring. The new initiative has come for quality of child facilities, for providing child-friendly services, and all our SNCUs, NBSUs, we plan to get them certified under National Quality Assurance, and the inbuilt quality improvement in the process. So what led to this rapid scale up? All these efforts have gone into it, but to mention a few, I would talk about that the commitment which is there at the highest level, health system strengthening effort, the data management, the quality improvement initiatives, having proper guidelines, tools, supports, institutional mechanism, as well as financial supporting. So moving forward, whatever we have achieved, we are not, getting into that complacency, because we have SDGs to achieve, and the state variations, district variations to achieve, to address. So the midterm review is happening for ENAP, and we are preparing a roadmap. And as some pointed out, the district level action plans will be prepared depending on the context of the districts, so that we have a replicable model for our aspirational districts, non-aspirational districts, advanced states, non-advanced states. So we want to replicate, we want to have action plan specific to such kind of challenges in the districts. Strengthening of NBSU, strengthening of NICUs in medical colleges. Actually, medical colleges, training institutes, they need a lot of, because our strengthening has happened till district level, but we are now focusing on the medical colleges. Using the digital platforms, which COVID situation has given us this opportunity. So we want to use the digital platform in a big way, focus on quality of care. That is the, that is the pivot on which the newborn health will depend, and the further reduction in newborn mortality will happen on that. Having midwives, neonatal nurses, and special focus on equity, that is our backward districts. So this is the model we are having. This is in short that our newborn care units at the 3 different levels with family participatory care, supported by wings, MCH wings, KMC units, DICs, and lactational management units. These will be again supported by our data management, our mentoring institute at the state level, our quality certification of facilities, and and not, the least our home-based care. So this model is there, but we want to strengthen each point of it, and that is our future plan. Thank you very much for your patient listening.
Thank you, Dr. Sumita, for such a comprehensive presentation, and thanks to the leadership of Government of India and your contribution to it. The commitment and leadership has to be seen to be believed, and I have been there for 12 years and I can vouch for that. So great to hear that. And moving forward, most important lesson from India is also not only the systematic scale up, but how they have linked the care in the newborn care units with the care in the labor room, and linking the care in the facility with the care in the community, and also connecting it through a transport system. And these lessons will be important as we deliberate in the next couple of days. Now we will have the second presentation from Bangladesh, and then after the 3 presentations, we can have the question and answer together. And requesting Dr. Sumita, if you can please wait till the other 2 countries are done, and then we can have a combined presentation. Sure. Thanks so much. So from Bangladesh, we have now Dr. Muhammad Shariful Islam. He is the program manager and the National Newborn Health Program Manager and the IMNCI program. And he has more than 27 years experience, both in public health and especially in child health. So Bangladesh has done fantastic work, now nearly 10 years of this journey as well. So over to you, Dr. Muhammad Shariful Islam.
Thank you, Dr. Gagan Gupta. Good afternoon, good morning, good evening, while applicable. I must thank you, UNICEF and WHO for organizing this very timely and important workshop, and for giving me the opportunity to present on the Bangladesh update on small and newborn care. Before starting, I want to thank Dr. Ziaul Mutin and Dr. Shamina Sharmin of UNICEF Bangladesh for supporting me for preparing this presentation. Here, the slide show. Next slide, please. Yeah. Here, the slide indicates that this slide shows the divisions, administrative unit, and health facilities in Bangladesh. On the right side of the slide, from outer to inner circle, you can see the different administrative unit from national up to community, and the level of healthcare service delivery at primary, secondary, and tertiary level, including the population coverage. In Bangladesh, we have 162 million population, and among this population, the total live birth every year is 3.2 million, and among this 3.2 million every year, sick newborn is 25%. And preterm delivery every year is about 600,000. Next slide. The level 3 care for small and sick newborn is provided at medical college hospitals through a special newborn care unit, SCANU, and newborn intensive care unit, that is NICU, including KMC services. Level 2 care is provided at district level hospital through SCANU, including KMC services, and at sub-district level, which is called in Bangladesh is Kojela. The sick newborn are managed at newborn stabilizing unit, that is NSU, and if required, referred to SCANU for referral care. KMC service also available in all the sub-district level facilities. At the union and community level, the health service providers provide essential newborn care. Identify the sick newborn. Besides this, some level 3 care at NICU. Next slide, please. Yeah. In Bangladesh, total 54 SCANU are functional, among which UNICEF supported for 37 SCANU, which is indicated in light blue color, and the rest 17 by government, which is deep blue in color, and other partners. 8 SCANUs are in division level, providing level 3 care, and rest provided level care in district level. 15 districts does not have SCANU yet, despite Government of Bangladesh plan to cover all 64 districts with SCANU, which is indicated here in orange color. 76% districts have level 2 plus inpatient care unit, and 100% level 3 care has CPAP support, and 8 level 2 care SCANU have CPAP support. And during COVID, liquid medical oxygen system was established in 142 facilities, 30 by UNICEF and other by the government of Bangladesh, which build oxygen capacities including SCAN. We have planned to introduce CPAP in all SCAN gradually. KMC service introduced in 266 facilities so far, and total 11,969 small babies received KMC till October 2021. Next slide, please. As a result of these initiatives by the government and partners, the newborn mortality rate has decreased substantially, which is low, which is now 19 per 1,000 live birth, and Bangladesh is likely to achieve SDG target before 2030, I think. Next slide. The National Neonatal Health Strategy was developed in 2009, which set clear strategic directions for small and sick newborn management through establishment of SCANU and KMC services. Based on that strategy, SCANU were piloted in 2012 with the support of UNICEF. In 2014, a strategy for scaling up of SCANU and SOP were developed, indicating a strategic plan for scale-up. Deployment and retention, capacity development, quality improvement, indicator setting and tracking, and establishing referral linkages. Bangladesh Every Newborn Action Plan was developed in 2015. This year, we have updated the National Newborn Health Strategy and now working on updating the Newborn Action Plan based on updated Global Every Newborn Action Plan indicators and national strategy. Next slide, please. Yeah. SOP detailed out the standard for an ideal SCANU, which explains space for scan, SCANU bed calculation, layout design, human resource procurement, and maintenance of equipment, quality improvement of scan. Next slide. Next slide, please. The picture shows that you can see the layout of level 3 care SCANU at Medical College Hospital, which has ICU zone, step down, KMC, etc., and have provision of CPAP and ventilators. Next slide, please. In this slide, you can see how we can see a layout of level 2 care SCANU at district hospital, which has ICU support for 3 to 4 beds, also has septic zone. Next. Next slide. Next slide, please. Yes. So far, more than 80% doctors and almost all nurses working in SCANU and NSU have been trained up on ITAT, Mother Care, and SOP. In addition, last year we have initiated capacity development on the rational use of oxygen for hypoxia management in SCANU, NICU, and NSU in the platform. In the program is ongoing to roll out throughout the country through government plan. To develop the capacity of managers, We are also providing training on newborn toolkits. Next slide. Next slide, please. And as per SOP, the standardized equipment have been procured for all SCANU and NSU. The maintenance and repairment is ongoing through UNICEF and Save the Children support. Budget and equipment maintenance plan has been included in hospital service management import operation plan, which will be continued in the next operation plan also. Next. SCANU and NSU human resources are managed from the existing pool. At level 3 care, neonatologists, medical officers, and nurses are providing support. In level 2 care, only trained medical officers and nurses are supporting. In some district hospitals, pediatric consultants are also supporting wherever. A dedicated organogram for SCANU has been proposed, and which is under consideration of the Ministry of Health and Family Welfare. Next. Next, please. To improve the quality of care, Center of Excellence has been established in Bangabandhu Sheikh Mujib Medical University, which is situated in the capital city of Bangladesh. A monitoring and mentoring system has been developed through regional roving team, engaging the professional bodies from Bangladesh Neonatal Forum, Bangladesh Pediatric Association, Bangladesh Perinatal Society, and OGSP, and their local chapter to ensure WHO quality of care standards. On-site capacity built for increased use of data for quality improvement through coaching, mentoring, and learning. Any problem?
Everyone requesting, please mute yourself. Yeah, please, you can go on. Dr. Mohammed, you can go on.
Dr. Sharif, I think you are muted.
Can you hear now?
Yes, very well.
Online network for monitoring and mentoring has been established using CCTV camera network, which is proved effective during the COVID-19 lockdowns. Next slide, please. And the reporting and monitoring system, record keeping, reporting registers, tools, monitoring checklist for SCANU, NSU, and KMC has been introduced in all facilities. Individual case tracking system for SCANU has been established using DSIS2 platform, and a SCANU dashboard is functioning in DSIS2 platform. Routine review and performance tracking is being done using the data from DSIS2 dashboard regularly. And we are giving feedback to the district and proposal level managers regularly. Next slide. Government of Bangladesh launched the National Newborn Health Campaign in November 2017, which are very effective for raising awareness and improved care. Social media campaign is also launched and continuing. More than 750 million people reached in last 4 years. Next. Presence of newborn campaigns and a strong newborn working team, strong commitment of the government of Bangladesh, and strong advocacy and technical support and commitment of the development partners, ownership of the program, National Newborn Health Program with resource allocation and engagement of the professional bodies and academia and a strong data system are the key enablers in Bangladesh. Next. The main challenges are high case load in the SCANU. In some of the SCANUs, the number of beds is is less than the actual requirement. So it's causing problem in some facilities, inadequate skill, human resource, inadequate resources for scaling up of small and newborn care across the country, and lack of structured referral and follow-up system are the main challenges. Next slide. Our priority activities is in future policy advocacy to increase financing for small and sick newborn, human resource and capacity development, improve quality of small and sick newborn care, equipment operation and maintenance, establish referral and follow-up system, mobilize parents, family and committee also. Newborn resources developed by the country, you can see here the link for all resources that we have developed so far. There's the link, and you can easily visit these sites and you can see what we have developed so far, and you can get easily access here. Next. In Bangladesh, population coverage not yet done, and our energy support we have increased already more than 80 districts, ST health facilities, and we are the process is ongoing, and there are NICU in 10 medical colleges and universities. Well, there is only one university, and in addition, there are 4 NICUs in private sectors also. So that's all from my side. Thank you all. Thank you for sharing.
Thank you so much, Dr. Mohammed, for such a comprehensive presentation. And what we have seen from both India and Bangladesh is that SNCUs is not only about equipment, it's about the whole issue of infrastructure, human resources, equipments, financing, data systems, and a strong linkage with the community. Now, one of the important things which we saw a bit different between India and Bangladesh was, in India, a lot of this has been done through the national and domestic resources, with the initial pilots coming from UNICEF and NIPI. While Bangladesh is another very good model where the resources have been pooled. Some places it has come from the domestic resources and some places from the support of the partners. And moving forward, for those countries who are planning this journey, it would be important to create a pool of resources, and that can come through a mix of domestic or partner or through the national resources itself. So we will see more about it when we go in the next 2 days. Thanks, Dr. Mohammed, and again requesting you to please stay with us till the third presentation from Vietnam is done. And let me now invite the Vietnam team and Dr. Tran Thi Hoang, who is the Deputy Director at Da Nang Hospital for Women and Children. And I had the pleasure of visiting Vietnam and this hospital 6-7 years back, when our colleague Ornella had organized a meeting which was a global meeting, in fact, and I saw the wonderful work which Vietnam is doing. So over to you, the Vietnam team and Dr. Hoang.
So hello, everyone. Thank you very much for this great opportunity to present to you on behalf of the Vietnam team our story about inpatient small or sick newborn care in Vietnam. So during this talk, I would like to talk about the neonatal mortality in Vietnam, and then the care for sick or small newborns including the early essential newborn care, the kangaroo mother care, and the care for sick newborns, and our challenge and the direction. So Vietnam, as we know that we are in the Western Pacific region with another 36 countries and territories. And our neonatal mortality right now is greater than the regional mortality. And for that, we are included in the group of 8 countries for priorities to do the newborn action plan to reduce the neonatal mortality for the region. Sorry. And so for so that's something. That my slide doesn't work. Let me see.
We can project from R and can someone take care from R?
Can you see my slide right now?
Yeah, we see your slide. Is it moving? Just check.
Okay. So the slide on neonatal mortality in Vietnam.
It's saying 8 priority countries accounting for 96% deaths. Yeah, it's moving now. Yeah. Awesome. Yeah, it's fine.
So you can see the neonatal mortality in Vietnam for the last 3 decades that have improved a lot, but neonatal mortality still accounted for more than 50% of under 5 mortalities. And the most common problems is prematurity, infectious asphyxia, and congenital malformation. For the government level, we do have the big party resolution on strengthening the protection, care, and management of people health, and including the objectives to 2030 to reduce our neonatal mortality and the under 5 mortality. So for our country action plan, up to 2025, we aim to reduce under 5 mortality to less than 19 per 1,000 and the neonatal mortality to under 9 per 1,000 live births. And we also aim to increase our early essential newborn care coverage to more than 75%. So we would like to tell you more in details on early essential newborn care and kangaroo mother care. And this package has made a lot of changes in our neonatal care. Before 2014, we haven't done any skin-to-skin contact right after birth. But since we implemented the package from WHO on early essential newborn care for the regions from 2014, then we started with the decision from Ministry of Health for early essential newborn care for normal delivery and cesarean section babies. And also in that year, we also issue the national guidelines on kangaroo mother care. And we started training for a lot of trainers from provinces on early essential newborn care and lately for kangaroo mother care. And we also included these criteria of ENC and KMC in our health reporting system. And we also do the biannual review for the whole countries since 2015. And so up to now, 100% of our health facility of national and regional and provincial levels have implemented early essential newborn care, and about more than 85% of health facilities at district levels also offer the early essential newborn care. For the kangaroo mother care for preterm and low birth weight babies, we are in the process of implementing at nationwide level. And right now, 4 national and regional hospitals and about 54 provincial hospitals are implementing kangaroo mother care. And according to our MCH reporting system in 2019, about 75% of our live births received EENC, and about more than 30% of our preterm and low birth weight baby receive kangaroo mother care. And here is some activities about the annual implemented review, and we also want to show you some progress in terms of the figures on our practice among skin-to-skin contact and early breastfeeding for our preterm babies among 48 hospitals in Vietnam from the regional, provincial, and district level levels from 2017 to 2019. So we can see here more than 70% of our preterm babies receive early skin-to-skin contact, but only under 35% had breastfeeding before separation. So these are some areas we need to improve. And by level of for health facilities at Center of Excellence, we have 3 Center of Excellence for ENC and KMC. We see the skin-to-skin contact was provided to more than 80%, up to 90% of COE, but just about 70% of provincial level. And the breastfeeding practice not very well done on the levels. So we have about 60% in national regional levels, but only under 40% in district level. And here we can see the breastfeeding practice, any exclusive breastfeeding for preterm babies now still under 50%. And here is by level of health facility. Breastfeeding seem to be better in district level, but for the whole exclusive breastfeeding, again, the national level is better than the district one. For other care for our low birth weight babies, we have the vital sign or monitoring every 4 hours during the first days of life, better in the national, regional, and provincial hospital rather than the district hospital. And then again, the kangaroo mother care during our annual review in 2019, the kangaroo mother care in the hospital we review the central hospital is better than provincial or the district hospital. And importantly, the magnesium sulfate haven't been given routinely in many levels of our settings. And here is the staff training about ENC. And we can see here for doctors and midwives in the delivery areas with more than 70%, and the nurses, but in the nurses in the neonatal unit haven't been coached with the high percentage right yet. And here, when we review the availability of medicine and supplies in hospital with neonatal intensive care by the level of health facilities, we see that at the district level, the CPAP only were available in less than 40% of our district hospital. And, you know, even some basic instrument tool for newborn resuscitation is not always available as on the level of care. And for syphilis and HIV tests, especially syphilis, haven't been tested and antenatally well in our health facility, especially and provincial and district level. So what we've done and what we've seen here, that early essential newborn care and kangaroo mother care, since we implemented at nationwide, we have seen some great outcomes from that. So we see at our hospital, after the early essential newborn care implemented, we reduced about 30% of neonatal intensive care admission to our hospital in Da Nang. So the Da Nang Hospital for Women and Children, we have more than 15,000 of live births every year. And so since 2014, end of 2014, we did the early essential newborn care after 3 months, and we recorded the number, the figures before and after the early essential newborn care. We found that 30% of NICU admission were seen, and you can see other outcomes of our neonatal care, that is hypothermia and infections also significantly reduced. And the exclusive breastfeeding have doubled, and the kangaroo mother care also improved significantly. We have nearly ruled out formula feeding in our hospital, and that also lead to great impact on financial expense in our hospital for formula use. And so for kangaroo mother care in our countries, we can see about 40% of hospitals were asked in 2018 when we did a survey at national level. About 40% of hospitals implemented kangaroo mother care, and with nearly 40% of those hospitals have more than 5 years experience in implementing kangaroo mother care. And here is a pictures of our KMC implementation from early. These babies are 29 weeks gestational age and receive a CPAP on skin-to-skin contact position, and then other pictures, different pictures. But this we can do the continuing kangaroo mother care from immediate after birth to postnatal care in recovery area, in operating room, or even after normal delivery, and also back to the postnatal ward or the neonatal intensive care. And here you can see the patients after cesarean section with kangaroo mother care, and then when the here in the picture in the neonatal unit, when the baby after that they stable. And during the COVID-19 pandemic, we also try to maintain the kangaroo mother care and early essential newborn care for both normal women and also women with COVID-19 positive. And these babies with very small and very preterm also was given kangaroo mother care as soon as possible, even they are on non-invasive ventilator. For the care for small and sick newborns in Vietnam, just to summarize the 3 levels from national, regional level, provincial levels, and district levels. We have at national and regional level, staff have the majority of staff was specialized in neonatal care, and we provide level 3, or some hospital can provide level 4 with medical and surgical NICU with high ventilator and other some had technology. But for provincial hospital, we have 64 provinces, and the level of NICU care around the countries have varied. It depends on the staff capacity. Some hospitals have a neonatal training, neonatal staff, but the majority have pediatric staff, and even some hospitals have they use the general nurses and pediatric nurses, just the mixed staff. And based on the staff capacity, some NICU, provincial NICU have a level 2, some level 3. And for the district hospital, the majority, they use maybe general doctors with some basic training in neonatal care, but others may have pediatricians, some have an obstetrician to care for the newborns. But only about 10% of the district level have a level 2 neonatal unit, with majority have no CPAP. They able to manage only jaundice and common infections. They can manage baby from 1,500 grams, but depends on their capacity. Some hospital may keep the babies 1,500, but some hospital only can provide care from 2,000 grams, 35 weeks or older, to rather than smaller. So one of our challenge is the health facility, the equipment is not the same anywhere. And you can see here the referral system is very, some on the back and mat and use during the transport. And we also try to take advantage of kangaroo mother care during the transport system, because we don't have the net transfer with the incubator or ventilator properly. So we use whatever we have at each level. So in summary, what is the challenge of our country right now? We have big gaps between the remote and these rural areas, and about infrastructure, in equipment, human resource, and staff rotation. You know, sometimes we train for staff for some years or some months on neonatal care, but after few months or few years, the hospital leader just rotate them to other department. So the neonatal care at different hospitals just vary and changing a lot. And lack of monitoring and technical support from higher level to lower level. And we also a lack of reporting system, although we included in some hospital standard level, but many criteria haven't been asked frequently. And especially we lack of equipment and medical products for small or sick newborn care throughout Vietnam. So for future, we think that we need to improve our technical and financial support for implementation of new neonatal action plan. And also we need to strengthen capacity building, monitoring system, and especially we need to update our quality improvement measure, need to establish a hospital ENC team. You can see our annual review that can show us significant outcomes and current situation. And these things need to be done continuously and need to develop criteria for excellent center of early essential newborn care, because these are the basic and the foundation for every newborn arrived, and to prevent the sickness, the infection, respiratory distress, and other things. So, and also very important for small babies. So, and then we need to improve our reporting system and keep trying to sharing and training for on the levels. Again, as we you can see the story on our ENC and KMC, we need to scale up these and on the KMC and ENC through on the levels of care in Vietnam to make sure that these are done properly in district hospital. And also we try to update the guidelines and training for on the health facility about the inpatient small or sick newborn care. And we need to have a criteria for each level of health facility and to make sure that it's done properly. And then we also need to improve the neonatal transport system based on what we have here. And again, finally, we need to establish a functional neonatal network from national, regional to district hospital to enhance on the good practice, especially ENC and KMC, and then the neonatal unit and also the neonatal care focusing and improve the training and implementing for the district level. So, and finally, we can see the neonatal care in Vietnam. We haven't been we have focused and who got the investment from our government and different partners, WHO, UNICEF, and others, to support our newborn care. And throughout the last decades, we have an improvement a lot, but a lot of gaps need to be done, and a lot of job need to be done to improve our healthcare system for the newborn, to make the equality for the whole system from district level to provincial and to national level, to help every newborn arrive to have the best start. Thank you very much for your attention.
Thank you so much, Dr. Tran, for a very comprehensive presentation. And what stands very strongly from your work and data is that very good integration of inpatient care for small and sick with the kangaroo mother care. And I think this is something which other countries will need to learn more from you. And we can, in the next couple of days, dwell a bit more on how do we integrate these two things together, because they need to go together, the kangaroo mother care and the inpatient level 2 newborn care. And it was good to see even data of the babies on CPAP and ventilators being provided either intermittent KMC or continuous KMC. Moving forward now, we have 3 countries and their government representatives with us. So I would request Dr. Tran, Dr. Mohammed, Dr. Tran, Dr. Mohammed, to please put yourself on the screen. And we have Dr. Sumita from India, requesting Dr. Sumita, if you, all 3 of you can please put your cameras on, and then I can run a few questions through all of you. So I will give you a breather, Dr. Tran, and I will start with Bangladesh. So the first 2 questions for Bangladesh, one is from Patricia from USAID. She's asking that is there family involvement at some level in the care in Bangladesh? And very much related question is there lactation support in the newborn care unit? So the first 2 questions to you, Dr. Mohammed, one is around the involvement of the families in the care, and second is about the lactation support.
Yeah, family support definitely is very important, and from the community level to the community, we have community clinics, and at both the health companies at the primary level, where the families are very much involved in the newborn care, and the families are well aware about the newborn services, and those families are very much involved in the newborn care, and the families come to the ANC corner and PNC corner, that means before delivery and also after delivery, for seeking service of the newborn. Thank you.
Thanks. So the next question is to Dr. Sumita. Thanks, Dr. Sumita, for staying, and we really appreciate that. There are a lot of questions actually for India, but I will start with a few. So the first question is more about the health workforce. So there's a question from Jagannath Sharma from USAID Nepal. He wants to know that who provides the newborn care at level 1 and level 2 in India? Are they medical doctors or paramedical staff? And another question which is related to the health workforce is, are the nurses in the level 2 facilities specialized neonatal providers? And does India have a certification for neonatal nurse? So the first 2 questions on human resources for India. Over to you, Dr. Sumita.
Okay, talking about HR, at level 1, we have medical officers at the NBSUs, and the nurses are there, and they are being trained in, they used to have training in LBNC, now they are being trained in special NBSU training program. So this is the situation at our level 1 care. At level 2 care again, we have positions, HR positions for pediatrician or neonatologist. Part 12 bed, if you can say, part 12 bed, there'll be either a pediatrician or ideally neonatologist, and there'll be nursing staff, for 12 bed, 12 nursing staff will be there. So they provide that care, and their capacities are built on facility-based newborn care, 4 days of training, followed by 10 days of hands-on experience. So that is the system here, but ideally it should be there, and most of our facilities do have it. But again, in certain districts, certain areas, that is a challenge for us. But with adequate training and all, we do it. For neonatal nursing courses, yes, the Nursing Council of India has come out with course in neonatal nursing, but at the same time, that is their pre-service training, and for our in-service training, we do have this facility-based newborn care trainings, as well as we are planning. We are planning that we'll have special, training for neonatal nursing because a lot of our kids can be looked after by them. The issue here is, being a very, very vast country. Covering the whole workforce with training, in-service training is an issue. Pre-service will be the ideal answer, but we are going for these specialized midwifery courses, and they will also be trained in nursing also, neonatal nursing also. So there's various ways we are trying to address these challenges.
Thanks. Excellent, Dr. Samita. And now I come back to you, Dr. Tran. And
I want another minute.
Please. Yeah, go ahead.
Because I was rushed through my presentation.
Yeah,
we have so much
to
speak about our efforts. I did not, or I could not adequately explain that our system of child, especially our SNSU systems and our health system, actually, we are very much helped by our partners, UNICEF, WHO, NIPI, USAID. So here we have developed a system where each state has been entrusted with one of partners. They, though funding and all, they are not into it so much, accepting in piloting and maybe some other ways, but technical support we do receive for our guidelines, for our trainings, for our mentoring, for our monitoring. So a lot of support is received from our partners.
Thanks, Dr. Samita, and we are all in it together. So now I come back to you, Dr. Tran, and this question is more about the follow-up system which is there in Vietnam. Can you please tell a bit about what happens to these babies when they are discharged? Are they followed in the community by the community worker, or they come back to the facility for the follow-up? Because that is one important critical piece which we have seen from other countries as well, that this link needs to be strengthened a bit.
So thank you for the question. So far, the majority of the babies come back to either the district hospital or the provincial hospitals for the follow-up. So not the smaller level, because I think that because the district level, we do have more staff to be trained in small and sick babies care. So our mother seem to trust the system like that. So in the district hospital, we have a staff available, not the smaller level. Yeah.
Thanks. So I come back to now Bangladesh again. And the question for Bangladesh is that a lot of units have also come through the support of the partners. So one of the questions which is there in the chat box is, what is the plan to sustain these units and ensuring sustainability for Bangladesh team? Over to you, Dr. Mohammed. Dr. Mohammed, it seems you're on mute. Maybe till we can get back to Dr. Mohammed. Dr. Samita, there's another question for you, which is regarding these district early intervention clinics. And this question is from Hema, from BMGF. And she would like to understand a bit more about the staffing and the kind of services which are being provided to the district early intervention clinics. So Dr. Samita.
DICs, they are special units for comprehensive addressing the specifically the delays, developmental delays. We focus on that. Our BSK program actually have 4 days, but DIC is basically for delays, and so SNSU graduates are linked to it from either through home-based care or from the facility itself. And there are a lot. The guidelines say a lot number of specialties, so that they all this eye, ear, musculoskeletal, all kinds of delays and defects can be actually addressed. But basically 4 core areas we focus upon: the equipments and the specialized services. They are either occupational therapists or physiotherapists, the optometrists, the hearing specialists, and psychologists. So these are the 4 core areas, and related equipments and services are provided. But the list has pediatrician and all kinds of whatever foreseeable problems these children might be having, so that all services can be provided under one roof. So that is the idea behind DICs, to give early management and to prevent disability arising out of it.
Thanks, Dr. Samita. And I will just try once more if Dr. Mohammed is there. Otherwise, I will request Dr. Shamina Sharmeen, who is from our UNICEF team in Bangladesh, to come over. And Dr. Jia is also there. So if Dr. Mohammed, you are able to respond to it, otherwise I will request Shamina to come in.
Dr. Sharif, thank you, Gagan. I think he's having some internet issue.
You can go ahead.
So,
please.
yeah, regarding your question, yeah.
Again.
Yeah, please go ahead, Dr. Mohammed.
Okay, please let me know the question.
Yeah, the question
I was
is
disconnected.
Yeah, so the question is that in Bangladesh, we have seen a lot of good work, and a lot of these units have also come through the partner support. So one of the questions in the chat box is, what is the plan for ensuring the long-term sustainability?
Yeah, I already mentioned in my presentation that the Bangladesh has now running the 4th operation plan, that is 4th sector program, where and the National Newborn Health Program has included in the operation plan from 2017, and this operation plan started in 2017, which will continue until June 2023. And the 5th operation plan likely to prepare after 2023, and I think government of Bangladesh will be able to take over the activities of regarding the newborn health, and I think it will continue.
Thanks so much. And what is important is to have a clear roadmap that where we move forward, and it's for all the other countries as well. So before we close, just one last question to all 3 of you, and that is very important question about the equipment maintenance. Would you like to say in short, is there any mechanism which has been put for the equipment maintenance, including the investment from the biomedical engineers in one of these things? And I can understand where this question is coming from, but a very important question. So, and then we will go for a break after this. Anyone can start, whoever feels that they have something to share about the biomedical engineers and the
Shall I respond?
Yeah, please start. Yeah, Dr. Mohammed, please go ahead.
Okay, thank you. We have technical, we have electromedical technical team in all districts, and they are responsible for looking after all medical instruments in the country. Besides this, the hospital service management has enough budget for look after these machineries. And now UNICEF, and with the support of USAID and Save the Children, is doing this job here in Bangladesh. And after the long term, if UNICEF and USAID Save the Children secure their support, and Bangladesh government will be able to continue, as there is enough budget in the hospital service management, who will take over this management of the SCANU, NSU, and NPCO. Thank you.
Thanks, Dr. Mohammed. Anyone else wants to come in from Vietnam or India? I think Dr. Samita from India.
Yeah. Is it on? Yeah. For our this thing, it is a health strengthening approach. So we have a special support. All of you must know that our under National Health Mission, which is the central supporting unit to the states. So we have a special head under equipment maintenance and all. So for that, the funds are given to the states. The states are free to engage their own system for equipment maintenance, and the equipments have been categorized into, critical and essential like that. So newborn equipments in our units, they are under critical category. So they have to be serviced. So there is a helpline, and the states have, according to their own choices, they have engaged people or systems. So this criticality of our instruments are taken care of. And in our Muskan certification, we have kept it as a quality indicator that at least 75% of that is the benchmark, that all equipment's functionality should be there. So we want to promote that way, and funding is given to the states.
Thank you so much. And Dr. Tran, would you like to come in?
Yeah, for the equipment in our setting, we have three sources of equipment waste from, not from the government, the local government, or from the national government. Secondly, from the hospital budgets, and thirdly, from the charity donors. So this is also an important part of our equipment, and how to maintain our equipment for the neonatal care. So in every hospital, even the district levels, we have a technician or engineer to look after the machine, on the machine in the hospital. But many of them they don't know how to fix the problems of the neonatal machines. So they have a link with the company who provide the machine to the hospital, so that then they can maintain the equipment well during. But this also very much depend on the budget they have, what the hospital to provide some money on how to keep the equipment maintained. So that is also important. And for the neonatal machine in Vietnam, we do have some local, the Vietnam company to provide a CPAP or phototherapy. So that is the advantage of our countries right now. But like invasive ventilator or other equipment, we don't have that, the national or the Vietnamese company. So sometimes it takes time for the local hospital to contact with the company to provide support in maintenance.
Thanks. Thank you so much. And thanks to all the three presenters, Dr. Sumita, Dr. Tran, and Dr. Muhammad. It has been great listening to all of you, and the conversation continues for the next 2 days. We will now take a 5 minutes break, and we will be back sharp by the clock at 0 hour, and which is 3 p.m. Geneva time. And we will now, after that, have the presentations from the Africa block. And that will be, again, a very interesting context to listen. So let's stretch ourselves a bit, have a cup of coffee, and then in 5 minutes, maybe let's reconvene. And we are running a bit late, but I hope we can manage. It was so interesting to listen from all three of you that we thought that let's let discussion go on. Thank you so much.
Thank you, Dr. Tashoma. Thank you all for the opportunity. My name is Yared Tadessa. I'm working here at the Maternal and Child Health Directorate of the Federal Ministry of Health of Ethiopia. My sincere apologies for the background noise, as we are very near to a construction site. I'll be presenting on the small and sick newborn care country status report of Ethiopia. We are having a population of more than 100 million, and geographically we have 80 zones with 1.1 to 1.3 million population. It differs from zone to zone. Under these zones are waradas, or what we call districts, 800 and plus districts. It keeps on increasing, and we are having a total live births of 3.3 million, and with a 3.2%. As per the mini DHS 2019, the neonatal mortality rate for Ethiopia is 33 per thousand. That is a bit higher than that of the DHS result in 2016, which was 29 per thousand. So there is an estimated number of 114,000 plus neonatal deaths every year in Ethiopia. When we see the context with regard to the program arrangement and service delivery, we are having a primary, secondary, and tertiary program delivery systems where routine MNCH services are organized. Primary health service delivery organized under a primary hospital with its catchment health centers and health posts, where we have the integrated community case management of newborn and child illness, the essential newborn care, the MNCI, antenatal care, the BMONC and postnatal care services being provided, including kangaroo mother care, referral linkage, and also services provided here at the primary level service. So at the primary, when we come to the arrangement of the neonatal ICUs, we have what we call the level 1. This is staffed, we'll see the HR arrangement later on, and they are mainly equipped with breathing or respiratory support like CPAPs and management for hypothermia, infections, and the likes. When we go to the secondary level, we have general hospitals where usually pediatricians will take the lead for inpatient care of sick and small babies. Pediatric hospital care is provided there, included with the comprehensive emergency obstetric and newborn care, where cesarean delivery and blood transfusion services are availed. So here at the general hospital level, we have level 2 neonatal ICUs where they are led by pediatricians, and we do have neonatal nurses and clinical nurses along with others, clinical and support staff. The tertiary or specialized referral hospitals, most of these are teaching university hospitals, where we do have few subspecialists, neonatologists, otherwise more or less similar with the general hospital setup, and they are equipped with the level 3 or the advanced neonatal care unit equipments, which we will see later on. One of the critical indicators provided is the kangaroo mother care service for small and sick babies, and we are having an admin report of a coverage of 62%, which is in absolute figures 20,000 or nearly 21,000 in the 2020 fiscal year. So we are having a slight increment of these small and sick babies, and also contributing much to the neonatal mortality in Ethiopia. Previously, neonatal infections and birth asphyxia used to lead the main cause for mortality. Nowadays, it is prematurity and birth-related complications are the main cause of mortalities in Ethiopia. So we do have around 367 hospitals in Ethiopia, with 67 under construction. So among these, 196 hospitals are equipped, and this has yet to be again audited because we are having more and more neonatal ICUs through the support of program partners and donors. So 196 hospitals, amongst which 80 are having level 3 neonatal ICU equipment, state-of-the-art level 3 neonatal ICU equipments. The staffing of this level 3 may differ from hospital to hospital, but 80 of them have been provided with advanced life support equipments, including ventilators and the likes. Hospitals with level 1 and level 2 neonatal ICUs are around 116. So among the zones that we mentioned earlier, among the 80 zones, we have at least one neonatal ICU per zone, if not for every district. Regarding the beds, we do not really have that actual data, and a true inventory has not been yet done. But the admission, again, shows we do have a high number of small and sick babies admissions, around 125,000 plus in 2019 and 123 in 2020. So when we unpack the components of this small and sick newborn care, we'll find that the facilities are assessed that for availability and functionality, and we are doing that currently as we are revising the National Newborn and Child Survival Strategy. So we want to do an inventory to scale up the small and sick babies related services throughout the country. So we are developing the 2021-2025 newborn and child survival strategy, including development. So the scale up plan will be based on these new strategies that we are going to endorse and declare very recently. So when we come to the components of care at the health post level, where the health extension workers are situated, the integrated care case management of newborn and child illness is the main service provided there, where newborns with small low birth weight at-risk babies are identified and linked to the catchment health center through a referral system. At the health center, we do provide essential newborn care, and recently launched the early essential newborn care capacity building course, which will strengthen the routine essential newborn care and early identification of complications, and then do the referral to tertiary, general, and primary hospitals. So we have a plan to scale the coverage of neonatal ICU services from the current 196 hospitals to 367 by end of 2025. And we have also the plan to improve the coverage or the access to newborn corners from the current 2,796, which is around 74% of the health centers, to 3,777 by 2025. So the budgeting for all these activities is channeled through the government, UN agencies, and the development partners. Some of it is earmarked, and some is through the SDG pool. There is also budget through the implementation of development partners like UNICEF and USAID projects in different regions of the country. We have not yet costed the level 1 and level 2 units in the country. We do have a national standard for leveling of neonatal ICUs in Ethiopia. It is yet to be endorsed by the senior leadership of the ministry and the Ethiopian Standard Agency as well. But we are using this draft document to standardize the service provided at each and every level of neonatal ICU. So the budget, apart from this, is also coming from the internal revenue of hospitals. So they do budget for maintenance and operational costs to run neonatal ICU and inpatient services provided at respective hospitals. So from the national to facility level, the Ministry of Finance and Economic Development through the Ministry of Health and UN agencies will channel budget through the regional health bureaus and the district health offices. So that is how budget is being channeled to the service delivery points. So when we come to the different levels and the size of the units, we do have, as I have said earlier, the standard. It may differ from hospital to hospital. There is a challenge with standardization. Otherwise, we do have a newborn corner, which is expected to be between 2 to 3 meters square per size, with a radiant warmer is kept. This is at every delivery room and at every operation room, the coverage which I have earlier described. Then the next level is level 1, where we have a minimum of 8 to 12 meters square of clear floor space, excluding the hand washing stations. And it is recommended to have 12 newborn beds. But most of our hospitals are designed some years and even decades ago. So most are not meeting these standards, but whenever renovations are done, we are trying to meet the standard set in the leveling of neonatal ICUs. So the special care units, the advanced neonatal care units, whenever new hospitals are built, it's a must that they do adhere to these standards. Otherwise, the hospitals which do exist in previously may not meet the standard set in this new leveling standard. So when we come to the critical services or service provisioning areas included in the design, at least, which we want to integrate with the hospital design, hospital construction design with the directorate, the infrastructure directorate here at the ministry. We have a NICU level 3 service provision area. So this will include step-down room where we with the mother, and an isolation room, and the room for KMC, at least for 8 beds for mothers with shower and toilet services, a triage space, not a room where mothers can stay while the newborn is under treatment, and 5 to 10 maternal bed with stable newborn. The main challenge here is the outborn babies, especially those mothers, because of the inadequacy of beds, that they are mostly separated from their babies. Ancillary services like offices, meeting office, libraries, liaison office, and the likes, milk expression rooms and counseling rooms are already included in the design. So we will include in the standard for the infrastructure design for hospitals in Ethiopia from now on. So the linkage with labor and operation theaters is also one other challenge in new hospitals, those recently built. This is very well articulated and very practical, but in those old hospitals, they may be floors away from the neonatal ICU. So staff need to carry the babies from one floor to another floor within, or from one corridor to another corridor, while for internal referral linkage. So we do have for this level 2 service provision area, which includes a step down room with the mother, isolation room for KMC, and now for 6 beds with mothers with the shower and toilet facilities. Ancillary services at level 2 are similar to the level 3, more or less they are similar in terms of availing the space. And the linkage is also the same, but when it comes to facilitation of referrals from the labor room to the operation theater, it is an ongoing effort, especially while they do their renovations. Otherwise, as I've said earlier, some are really very far away. The labor and delivery services are very far away from the neonatal ICU units. So we do have a standard list of neonatal ICU equipment that is included in the labeling and standard document. For each level, there is a special list, which is also having the specifications. So CPAP is also an essential equipment for level 2 care. We do have ongoing efforts to build the capacity of staff working at neonatal ICU level 2 and even level 1 to capacitate them with the knowledge and the operation of CPAP usage. So the current procurement mechanism of all these equipments for the inpatient care is through the Ethiopian Pharmaceutical Supplies Agency, a government agency, and through them most equipment and medical drugs are procured. But when you come to the special program or project of the 80 level 3 neonatal ICUs, which costed 27 million USD and funded by the ministry and partners, UNICEF is handling this as a turnkey basis, as a turnkey project through supporting the procurement, the transportation, installation and training, as well as preventative and corrective maintenance activities. Right now, the second round of preventive maintenance activities to be launched for these 80 hospitals with level 3 neonatal ICUs. Apart from that, capacity building activities have been provided regarding the equipment operation and equipment handling and the clinical use of these advanced high-tech equipments, which are very new to our hospital staff. So repairing and maintenance usually done through the biomedical engineers and the biomedical technicians located at the tertiary and general hospitals, and they are also responsible to provide support to the catchment primary hospitals and even to the health centers. Functionality has some limitations here. Otherwise, following this neonatal ICU projects that we are working with UNICEF, the modalities to transfer the skill, and also the local biomedical engineers will take over the overall capacity to do the maintenance. But we do have the shortage of these engineers and technicians. When we count the HR needs for small and sick babies, including the capacity building and program supportive supervision activities, we do have at tertiary level a handful of neonatologists and also pediatricians. Most are located in the towns and cities. For primary hospitals, the general practitioners are providing or leading the clinical service for small and sick babies. We also have neonatal nurses in the last 3-4 years. This is one of the major shifts in specialty care for small and sick babies in Ethiopia, where we have neonatal nurses as a bachelor and as, of course, and also as a master's level trainees. So we also have clinical nurses and data clerks and biomedical engineers and technicians, along with the support staff for housekeeping. Our in-service trainings include the neonatal ICU basic training, which is used to be for 28 days, now revised very recently and awaiting endorsement by the Human Resource Development Directorate. We have reduced it to 21 days. We do have also, in collaboration with UNICEF, with the Ethiopian Pediatric Society, CPAP skills and coaching activities, and also trainings regarding the clinical use of CPAP machines. We just launched the early essential newborn care training in collaboration with UNICEF. We have the Helping Babies Brave and Helping Babies Survive courses, the BMONC and CMONC, and the neonatal ICU equipment use and preventive maintenance that I mentioned earlier. And also, as a modality of quality improvement, we have started, though not regular, mentorship by neonatologists, pediatricians, and neonatal nurses, even though it is consistently implemented. We have selected, in collaboration with UNICEF, 50 learning hospitals where we want to use them as learning centers, and they will serve, or they will be acting as centers of excellence to support their catchment hospitals. So rounds of capacity building activities, especially when it comes to the use of CPAP machines, have been done already. And the other is a collaboration with UNICEF and Vermont Oxford Network, spearheaded by the Ethiopian Pediatric Society, to create a pool of CPAP trainers from 50 learning hospitals and through the Ethiopian Neonatal Network, which aims to improve the quality of service in neonatal ICUs in selected hospitals. So this has already been launched and it is ongoing. It is expected to improve the skill of the NICU staff, especially when it comes to the use of life-saving equipment like CPAPs. As a pre-service, we have the neonatal nursing and the neonatologists. These are very new developments when it comes to Ethiopia, but we do not have yet the dedicated budget line for national and district plans. Regarding the staff retention mechanisms, there are hardship allowances. It may differ from one region sub-nationally from another region, but some are providing hardship allowances for neonatal ICU staff, some providing housing, transport services, and further educational opportunities as any other health provider or professional in the country. The transfer of experienced staff to higher centers is also one modality to retain staff, to retain from living to the private sector. So more professionals with a better expertise are transferred to the centers and to the cities where level 2 and level 3 neonatal ICUs are situated. So there is no such regular rotation. It is a need-based, but once they are trained on neonatal ICU trainings, they are expected to sign a one-year agreement at least with the HR of the respective hospitals, so that we will retain the skill that they gain through the trainings. So this is one modality of sustainable plan to retain. But we want to have more neonatal nurses to have a very sustainable plan instead of holding staff from rotations, be it internal or transfer to other hospitals. So capacity building in various training guides is going on, from advanced neonatal ICU, which we also had the advanced for pediatricians, advanced neonatal ICU clinical reference manual. This is a pocket reference manual recently launched to be already distributed to selected hospitals. So this will also improve the case management skill of physicians, pediatricians in remote hospitals in Ethiopia. We have also the BMONG training package, the essential newborn care training package, the basic neonatal ICU training manual, the management protocol for neonatal ICU. These are quick references as well. The neonatal ICU level and standard document, and the early essential newborn care training manual. QI improvement system.
Sorry, Dr. Yarid, can you wind up in 2 minutes?
Okay, okay.
Yeah.
So the quality improvement system, we do have the basic trainings followed by post-training follow-ups, and also the mentorship provided by neonatologists, pediatricians, and neonatal nurses. We do also have the quality of care networks, the Ethiopian Neonatal Network, which aims to improve the service quality through on-site support that I have mentioned earlier. Regarding data, most the small and sick babies indicators are already included in the HMIs or the DHIs too. These are at the facility level. Data recording and reporting is conducted by the head nurses and the HIT at districts, zones, and hospitals, which comes monthly reported to the hospitals. So these are the indicators: the early institutional neonatal days, the neonatal ICU treatment outcome, proportion of low birth weight for whom KMC initiated, amongst others. So we also have regular quarter review meetings through nowadays virtually with the CEOs and medical directors of the hospitals, which usually depends on the connectivity of the internet. Otherwise, we do follow them annually through program reviews. One critical point here is the referral linkage in the use of ambulance service. It is very challenging. It is also not well equipped and newborn friendly. Regarding the ROP screening, which we did not hear previously, we do not have a policy, but nowadays we are facing numbers of cases of retinopathy of prematurity due to the improved survival of small and sick babies. We do have only one follow-up in one hospital here in Addis, and otherwise we do not have standard policy or follow-up for retinopathy of prematurity. So when it comes to the developmental care, the early childhood development section is already integrated into the training manuals of the neonatal ICU and also the IMNCI. So developmental supportive care is yet to be initiated. It is just integrated very recently. So key enablers, we have a commitment and leadership from the senior leadership here at the Ministry of Health. It is one of the flagship initiatives. Strong the child survival technical working group focusing on neonatal ICU. Strong partnership with multi-stakeholders, including societies and the academia, USAID, UN agencies, WHO and UNICEF in particular, and universities. Innovation and evidence generations, scale up the KMS, the kangaroo mother care, and the research advisory council here at the maternal and child health. Clinical mentorship activities, and these are also one of the key enablers for the improvement we have seen so far. Key challenges: lack of financial and human resource, very inadequate and very inequitable across the country. Also inadequate infrastructure, including basic amenities, lack of local suppliers and spare parts. They are using and reusing supplies and spare parts, especially nasal prongs. We have a gap in access and quality of healthcare during the perinatal period, lack of policies and unavailability of life-saving medicines, including parenteral nutrition, caffeine, and also surfactant and other supplies. Inadequate infection prevention practice at health facilities, low newborn health care seeking overall from the community side, and low performing maternal perinatal days surveillance response and weak vital registration system. The way forward, domestic resource mobilization. We are working with the partnership and collaboration Directorate of the Ministry of Health on domestic resource mobilization for newborn and child health, standard or endorsing the standards for infrastructure designs, the capacity building and coaching through mentorship, neonatal ICU equipment preventive maintenance, strengthened through the NICU project, and capacity building and QIs on infection prevention practice. We have just revised most of the training guides. We have not yet uploaded to the ministry's website. When we do, we will definitely share to the country teams. So we'd like to thank UNICEF and WHO country teams while developing this report. Thank you very much for your attention. Back to you.
Thank you so much, Dr. Yared. Thank you so much for great presentation. Colleagues, please keep your questions at the end of all the presentations. We are happy to note that 74% of the delivery facilities have neonatal corners, and also CPAP is part of the essential equipment list. However, we have noted issues also around equipment maintenance and referral, and also lack of dedicated budget. Budget is coming from different sources, which is very good, but having a dedicated budget and neonatal nurse would be an important support to advance neonatal care. So now let me call upon the next presenter, which is Malawi. Let's try to keep to time so that we'll have some time for discussion. We have important questions in the chat box, which we need to entertain. So let's try to stick to 15 minutes as much as possible. Thank you. Over to you, Dr. Misandani. Over to you. Thank you. Briefly introduce yourself and take the floor. Thank you very much.
Thank you very much. I'm Dr. Msandeni Chiume, and I am the head of pediatrics at the Kamuzu Central Hospital with interest in neonatology. Kamuzu Central Hospital is one of the referral or tertiary centers in Malawi, and also one of the lead investigators in the neonatal program. And so also serve nationally at the Newborn Steering Committee, and I'm happy to be a part of this discussion this afternoon. So I was waiting for my colleague to just stop sharing their screen so I could start sharing mine. And now I have an opportunity. So basically, I'll take you through this presentation for Malawi. And the background and the outline is that we'll have the black background. We have a bit of statistics. Then we'll talk about the small and sick newborn, the human resources component, infrastructure bits, procurement and deployment of equipment, data systems, and how we monitor. We'll also look a little on the referral systems, discharge, the family-centered care, communication, key challenges, but also think through some of the materials that we've developed for global learning in this nation. So Malawi is a small country in Africa, right there. And if it translates to this sort of appearance on the map, it has 28 districts, which are divided into regions, northern, central, and southern regions. And it has administratively 5 zonal offices. And each district is taken care of by the Director of Health and Social Services. Most of the healthcare is provided due to public adventure, so mainly government, but we have a few private for-profit and private for non-profit facilities. And then government is the primary provider. Our levels of care mainly four. So we have the general community level, where then we have the primary, secondary, and tertiary levels. Our population is quite huge for the country that it is, the small land that it is, and we have a really rapid growth rate of 3.7, with a birth rate of 33.4, and of interest is our adolescent fertility rate is also pretty high. Maternal mortality rate is dropping, although we are still on the high end of things. We would like to see it improve. We are hovering around 439. We are proud to have a skilled attendance birth rate at 90%, although we would like to be at 100%, but this is not a bad achievement at all. We still have plenty preterm deliveries of about 18%, and our neonatal mortality rate hovering around 30, right now at 27 births per live birth, per 1,000 live births. And if you can see the chart just on the end there, which shows how we managed to deliver the under 5 mortality reduction with the MDG4, and infant mortality also went pretty nicely down, but the neonatal mortality indeed stepped down, but not very much, dropping from about 40, hovering around 27, 30, thereabout. Still a lot of work for us to think about as a nation. So here we go. As of this discussion, I will talk a bit more about how Malawi took the journey of improving the neonatal care in the country. As of 2013, and at that point I was only a registrar in pediatrics, Malawi only had mainly KMC units. And I recall one of my projects being going to the KMC units and to see how much of the KMC is still in place, and do people actually have the right resources, looking at heaters and cups for feeding and all sorts of things. And it was a difficult situation to see. The knowledge was there, people were there, but no equipment. Even where there was equipment, no backup plans, for example, for like power and stuff. But things have transitioned quite a lot since the 2013. So mainly it was KMC units and a few sick and newborn units in the central hospital and in a few private hospitals. And other sites had some places to nurse and neonate, but mostly it was in the postnatal wards with no real patient notes and no data. So basically the neonate was written their notes on the back of the mom's file and no record of what happened to these neonates afterwards. But as we speak this afternoon, we are proud to say that currently 54 newborn units in Malawi. Most of them are operating at about 80% of them are at secondary level care, meaning at least we are able to provide basic newborn care, warmth and KMC and general nursing. But we are now transitioning to CPAP, and only 3 of them are able to function at a tertiary level where you can go slightly beyond just the CPAP with consultant pediatricians and a bit more techniques that could be done at those centers. But from 0 to 54 newborn units, actually structures in the hospitals with designated newborn space and designated nursing staff and some equipment, CPAP equipment, warmth provision, all sorts of equipment available. I think that's a huge leap from where we were. In 2013, there was an analysis done looking at some of the bottlenecks, and this revealed a severe deficiency in the health workforce, affecting the quality of care of these newborns. Clearly, there were no dedicated staff for the management of the sick newborns, so no staff allocated for the neonate and the neonate was just benefiting from the same staff that were taking care of the moms in the labor wards or postnatal wards. The healthcare workers lacked knowledge, but more so confidence in the care of the newborns. When I went through some of the mentorship visits in the districts, it was I was sure that my clinical officers and medical officers had been exposed to neonatal training. But when we got there, the levels of confidence were very shocking until you held them by the hand and revisited how to do a lumbar puncture, how to prescribe for a neonate for quite a while, then confidence came in. And then protocols were there, but not to address specifically a neonate or a newborn infant. But fortunately, there's been the ENAP strategy. We've been working hard to strengthen and invest in the quality of care during labor, delivery, and neonatal period. And with this strategy and the engagement of the reproductive health unit, we've indeed managed to deploy quite a number of staff. So apart from this project that supported the building of small and sick newborn units in the districts, then we get a deployment of staff now through our nursing colleagues into these very units. And it's a pride to actually walk into centers right now that are fully nursed by the nurses. There is still a focus on building capacity, both in service and pre-service with the health workers. So we have the College of Nursing that have been, so we've reviewed the curricula in a way that it incorporates newborn care, but also the devices that newborn care is receiving in these districts. But also after they're trained in the universities, then they come to the wards and we also give refresher trainings, but also the staff that haven't been trained are being trained on these newborn protocols. These protocols are called the Malawi Care of the Infant and Newborn, the COIN. His newborn care tailored to our setting. As you know, that evidence is only as good as its setting. So due to the understanding that we are a low-income country, we have equipment and resource challenges, it was paramount that we review these guidelines and match them to the environment that we live in. And it is now of pride to see that there's good development of collaboration between the healthcare workers, the ministry officials, and the professional bodies in our nation. The Pediatric Association has been very key in producing some of these materials. There's been evidence-based, locally relevant course now, which is being given, takes about 5 days to deliver and covers all the key components, including things like referral and documentation and all that. And all the audience is really the nurses, the clinicians, and in our setting, very proudly so, engineers are also part of this course. Now, these are an important aspect of this course, which other disciplines have actually shown interest in learning how we have engaged them. Most of the times we've worked with equipment, and in neonatal care, you need a lot of equipment. And when they break down, they became equipment graveyards. We didn't know how to take care of them, and the engineers didn't know sometimes how to get cues from us. And equipment were just broken and stayed as equipment graveyard. But it's now quite a joy to work together with engineers. They understand us through this course, and we also get in active interaction, and we can call upon them when we need support with equipment without a problem, because rapport has been built. And now there's approved by regulatory authorities, and there's targeted in-service, pre-service trainings, but also trainers are generic course instructors and well-trained by the College of Medicine or College of Health Sciences. So as I said, we have strengthened our pre-service training and also the technical training institutions in the country. So for example, the Polytechnic and other training institutions have received training support and lectures. And we've now also developed skills labs in these training institutions to allow that early on hands-on practice that is required for you to gain the skills in managing these neonates when you're on the wards. We have a built-in mentorship program now, quite long-standing now. Several pediatricians are going out into the districts, giving out the best of what they have as skills on their hands, demonstrating to the young ones all sorts of things, including professionalism, how to be a good neonatal care, review the standards, and also then physically take care of these patients. These mentorship visits are actually being explored to see if we can include some of the virtual platforms as well, but not yet started. But this is one of the things that we're thinking seriously of engaging, because of the challenges of getting travel time for these very busy staff members or team members. Then there's also facility-based mentorship or champions that are trained at the facility. So once you go out as a pediatrician, your aim is to reproduce yourself in a way so that you're not always called. So once you develop a champion, one or two, you will look at your staff and pick out these key members that are standing out. You groom them a bit more and then let them go out and train their colleagues, and you follow them up as mentees, yet they also have another bunch of staff that they follow as mentees. And this model seems to be helping us to replicate our skills much faster than we could if we just did one-to-one all the time. We have supportive supervision visits, but also quality improvement visits. In the country, our quality control is managed by the QMD, the Quality Management Directorate. But we're fortunate to have support from them in that they give us the technical people that can sit with the nurses and the team on the ground to come up with an analysis of their problems at that given point in time. To, for example, do a fishbone analysis or use a prioritization matrix to be able to look through their own system challenges and see if there were any low-hanging fruits or anything that they could do to improve their situation. And together with the supportive team that has come to support them, then come up with action plans to hope to improve their settings as we go along. So this has improved also things in terms of service delivery, in terms of improving knowledge skills, and these visits are quarterly, and some of the training institutions are involved as well. And then after a couple of them visits, then the districts would come together and have a collaborative session where they share these experiences, not just from the QI visits, but also from their neonatal care experiences and if there are any challenges that they've been meeting. So far, we've had several of these sessions, and the teams look very enthusiastic, very stimulated, and find these meetings very helpful to one another. Just spelling out our HR needs so just to spell out our HR needs, our human resources.
Go ahead, please. Yeah, but try to wind up in 2 minutes, Dr. Nsende.
Yeah, I think somebody muted her by mistake.
Okay. So I've been given a chance to wind up. Our HR needs are, we have still needing committed healthcare workers in newborn. We're also needing to capacity build more using the coin. The use of the PPE, especially now with the COVID situations, we're still, I think, lagging behind in terms of provision of PPE for this for our human resource, and also providing a good working environment and working hard to provide more specialized newborn services. And then right now, our hospitals are not designed always as newborn units, but hospitals are being identified, spaces as being identified in the hospitals to facilitate newborn care, and facilities are now working hard to design these units better. And this is one of the current floor plans that has been approved. Initially, our facilities were always just as I said, a space out of the maternity wing. But now, when the districts set out to build, we have submitted a floor plan that would incorporate both the maternal needs, but also the neonatal needs, and hopefully work better that way. On the equipment issue and the maintenance, so most of our equipment is procured by the UNICEF and WHO and some other partners, and our maintenance is mainly through the Ministry of Health in the physical assets management, and we have engineers that are located in every district hospital and also national hospitals that help us repair. And as I said, we're working nowadays hand in hand with these engineers, making sure that our equipment are on point. Malawi has now an established referral system. It is from community, primary, then secondary levels of care. Mainly for transportation, we've been using ambulances, hospital ambulances, but I must say that they are insufficient because at the moment, we're still having one ambulance to 50,000 population, which is quite a huge population to take care of with one ambulance. And these transports are managed by the district hospitals. In terms of communication, mostly we're using cell phones to communicate to one another, and it's personal cell phones. And airtimes can sometimes be available, but it remains a challenge. I must point out that we had the wireless communication messages, but unfortunately now most of those equipment are broken down and not usable anymore. Mostly now people are using WhatsApp to give each other feedback. One could argue about issues of patient confidentiality and data protection with the use of WhatsApp, but it is seen to be an easy and user-friendly means, and people have naturally deviated to that means of use. On the family-centered care, there's active participation of caregivers is being encouraged in the hospitals. We still are lagging behind in terms of male involvement, but certainly we are working hard by giving out messages to encourage the same. Caregivers provide adequate amount of feeding during feeding times, and monitoring is done by the nursing care, and KMC babies are always given their caregivers. So on discharge criteria, I think for KMC, for those of us working in KMC, this is a generic, unless they are 1.5 grams. I know there's a discussion about the decrease in the weight, discharge weight, but at the moment we have still at 1.5 grams, and we are discharging them when they've gained 15 kgs per kg per day, and if the baby is stable, and then refer them to the health center, and then completely discharged out of the program if they're 1.8 grams kgs. When they are sick, we just stabilize them, make sure that they've retained to their normal vital signs and completed their prescribed treatment, and then we discharge. And in terms of counseling, we then have a few centers have follow-up, but I must say this is one of the weak areas that we need to pick up as a country in terms of neonatal follow-up and encouraging them to come back for follow-up. At community levels, the families go to the health surveillance assistant, the HSA. There's several of them in their catchment area, and the follow-ups are done on day 1, day 3, day 5, and day 5 for the small babies. The data systems are mostly paper-based and using the health management information systems, the routine data systems, but some of these are feeding directly into the DHIS2. We initially just had the neonatal mortality rate, KMC, and the community-based neonatal care, but now since 2020, we've increased the number of indicators to include the sick newborn in tracking in the DHIS2, which is also a great achievement. Great digital systems are under trials and hopefully to soon be expanded countrywide. So in terms of where we are at, Newborn Steering Committee is focused and is coordinating these activities, and the National Health Agenda is pushing through, and the ENAP is developed. Although we have a document that has expired, we're working hard to revise it to make sure that it's in order. With priority areas to still improve the training of the staff, spacing issues remain an issue, community engagement, and then our weak referral system needs to be looked at in total. Inadequate financing remains a big bottleneck. We have erratic drug supply sometimes, for example, vitamin K, and then inadequate staffing levels. And however, we have also limited support from the national team. We're working hard to continue on capacity building of these health workers and improving newborn care infrastructure and digitalizing our data. So the final slide should be this, and allow me to take a second on this, is that we have developed some good material in this country, or with the support of the teams in this country, is that one of the things is the health facility assessment checklist, and we also have worked together with our partners to develop the equipment target product profiles, but also the implementation toolkit for the small and sick newborn. And thank you very much for listening.
Thank you so much, Dr. Misandeni, for this great presentation. There is so much to learn from Malawi, if we have the time. So it's really important to note that Malawi has really taken the equipment maintenance issue seriously, and have taken to pre-service, colleague training, technical training institutions, established skill labs to address this issue. We are also encouraged that you are promoting family-centered care. And then we also noted that you have really integrated sick newborn tracking indicators into DHIS too. So there is a lot to learn from you. Participant colleagues, please keep your questions. Let's move to the next presentation from Sierra Leone. I would like to call Dr. Kenner to introduce itself and also take the floor. We are running a little bit behind time, so let's try to make the presentation as brief as you can. Thank you. Over to you.
Okay. Thank you very much. I am Dr. Sati Kene, the Director of Reproductive and Child Health in the Ministry of Health and Sanitation, and now currently acting as the Chief Medical Officer for the time being. Our program of trying to take care of the newborns and sick newborns in Sierra Leone is a child, as I can say it. It has some teething problem, but despite all the challenges, we've actually made some, remarkable progress as we see. Next slide. Next slide, please. Hello?
Can you change the slide, please?
I'm sorry, but it's not me who projecting the slide. I think it's Dr.
Hanging. The slide is hanging, but
okay. So maybe just refresh.
Yes.
If you are projecting your slide, I thought or her can help from our side.
Yeah, it's actually been projected from your side.
no, actually it's Asha and they are projecting, the UNICEF colleagues.
Okay.
Yeah. Okay. Fine. So can we go back to the beginning, please? Okay, so next slide. So for Sierra Leone, we have 5 provinces and 16 districts, and according to 2015 census, we are currently at about 8.2 million people who have 310,341 total live births as estimated for this year. Our neonatal mortality rate is 31 per 1,000 live births by our DHS. We have 22 tertiary hospitals and district hospitals, regional, that really does CMONC activities. For primary healthcare facilities that have BEMOC facilities, about 228, and the remaining are actually trying to handle level 1 neonatal services. Next slide. So in our journey from 2017 to 2021, up to 2019, we had only 4 level 2 facilities, and they were all at the regional headquarters. But then due to some, review and concentration to see how we can really step up, and we managed to increase it by 5 in 2020. And now, as we are even in the midst of COVID, we have gone up to 16 level 2 facilities in the country. Next slide. So the process of establishing, if you look at our data, we are reducing in the under 5 mortality, but the trajectory at which the newborn, the neonatal mortality was going was slower comparatively. So that was actually the zeal, the thing that gave us the zeal.
Sorry, Dr. Ken, can you put it on, is it on a presentation mode?
Yes, it's presentation mode.
Oh, okay, all right.
It depends on the computer they are using. So based on that, we decided to really focus on that, and we started in 4 districts in 2017, the regional districts. And what we did first was to really get an assessment tool to assess most of the facilities that we go in there. And then we developed a standard tool by the ministry and all our partners. And when we go into any facility, we know these ones we are not built with these facilities or with the facilities in mind. So we had to go and negotiate for space. We assess the facility, we debrief them, and then we look at what is needed to be done, the gaps and what we need to do. And then of course, we already have a standard procurement equipment list for level 2 newborn care, which we use to actually procure our equipment. And as during the same assessment, we actually try to identify staff that will be in there, because most of these areas are up in the districts where we may not have pediatricians, but then we may have the general medical officers, the physician assistants, and some nurses. And then of course, in the regional, we get the doctor, the pediatricians and others. We identify them, provide training to really be able to provide services to these children. And then whilst that training is going on, we also do some rehabilitations for the facility, get the KMC unit. We normally do it with mothers within space, rooms where they can sleep and where they can sit for possible breastfeeding and other things. And then we get the KMC all getting ready. When that is done, we get their equipment, then we install them, and then we normally get people to inaugurate. During the inauguration ceremony, that's where we call all the partners, the stakeholders, for them to know that facilities like this has not been existing, but it's now there, and it's an opportunity for them to really not be scared, because mostly children that are now coming in these facilities were abandoned initially when they were given birth to. Some of them will say, oh, this is a Devon, this is that. But with all during the inauguration and constant discussion with the people, at least the services have started coming up. Next slide. So this is just the journey, as it says, from 17 to 19, we had 4. In 2020, even in the midst of Corona, we had 5 added. And then this year, we've also added 7. So at least all apart from the 2 newest districts after the 2015 census, all the districts now have this level 2 facilities. Next slide. As I said, the jump started in 2019. We have a first lady who is actually a patron or an ambassador for women affairs and children. And that's her who, when they visited with the president in one of the BOB SCBUs, in our engagement. And of course, they actually gave us the zeal, the political will that, yes, we are doing much in those 4 districts, but we need to scale it. And for ethical reasons and for other reasons, we need to be in every district. And that was actually the beginning of our speed to make sure that we have these facilities established in all secondary hospitals. Next slide. So for infrastructure, as you see, this is it. In all the 16 SCBUs, we have about 218 beds. But what is important for us, because the others green, that means we are okay with it. But for the kangaroo care units, we have about 5 or 6 areas that were hospitals that haven't got space, or the space is there, but we've not rehabilitated it very well. For mothers within room, all the facilities have it, with the exception of 1 district, which is hospital, which is Cambia, and we are working to really get that functional. Next. Infrastructure continues. As you see in the amber or yellow, electricity is still a challenge countrywide. Not every area is using grid. So some areas are having generators, some with solar, and we know that is very expensive and challenging to maintain, given that we have a lot of instruments in that area and you need 24 hours electricity. When lights go off and the child is on oxygen and other things, you know what will happen. So that's a challenge right from the beginning. Of course, we have side laboratories in every SCBU that we have, but then we are still challenged to get a functional, comprehensive laboratory in all the districts as we go. Next slide. Okay, this is just a glimpse of some new SCBUs which we have recently commissioned as we go. Next. So since 2019 to date, I mean, our SCBU is actually divided every district for inborn and outborn. And in our own case, we defined outborn as children born outside the facility where the SCBU is. And then the inborn, we really wanted to compare and see how we can improve on issues within the facility where the unit is, because we know what the outcome of what goes into the SCBU starts actually during pregnancy. So we divided it so that at least that will give us an opportunity to do a lot of QI as we go. And as you look at it, we have newborn, outborn. Up to now, we were expecting outborn to really outweigh the newborn because you have more facilities outside, but even up to now, we have more inborns compared to outborn. But because of this, we have actually started our advocacies to continue. Of course, we are getting more males, but the interesting thing in here is we are gradually increasing or improving on the survival rates as more trainings, as more mentorship is going on, as more QI projects are going on. We are gradually improving. And this includes even the newest areas where we do not have neonatologists operating. Next slide. Of course, this is just showing in our kangaroo mother care units where some of how the mothers are practicing. You can see the very young faces, so you expect why you will be getting very, very, very small for dead children. And that is one of the areas the First Lady is also working on this to see how we can improve on the teenage pregnancy issues in the country. Next slide. For human resource, you can see we have 8 neonatologists or pediatricians within the system, and we have some local practitioners also who are generalists supporting the system. Of course, we have paramedics, but you can see every year we are getting more and more people to really stay. And of course, initially we had only about 50% of these that were government payroll, and the rest we are supported by our partners that support, but gradually we have over 80% of all our staff working there now with full government emolument. And government has made it a priority list to actually make sure that by 2022, we'll include everybody in this thing. So The hospital management is actually now with us, because at the initial stage, we used to lose most of this staff because they were rotated from one place to the other. But it's now an agreement with all the administrations in the facilities. All the staff remain in there and will progress as it is. Next slide. So these are the capacity building things we do some KI, some quality improvement initiatives with collaboratives. We do mentorship on the job training with the whole technical sessions. These pediatricians go around from district to district and most times also in communities to really train them on essential newborn care and other things. We mobilize our pediatricians in different SCBUs and go around. Of course, we also do training for KMC group and even perinatal death surveillance and response, which we do quarterly. And of course, now we have designed a 1-year post-basic neonatal nursing course because that is a priority. We need to improve on the nurses providing services in this unit. So that thing is going to start next month because it's already December in 2022. Next. So we already, as I said, we have a package, a newborn equipment package for level 1 and level 2 and 3, which we have developed and we are implementing it. Of course, we are mostly dependent on our partners, thanks to the FCDO that gives bulks of the funds, and we pass it as an arrangement with the Ministry of Health. Is being handled by UNICEF, and UNICEF also brings in some internal funds, of course, and the China fund. We are actually using much of these 3 funds to really do much of our work. Of course, government chips in with the personnel, chips in with drugs and other few things, but it's not really that significant as it is. But the interesting thing is all our 16 SCBUs are fully equipped and all of them have CPAP machines as we go. Next. At the beginning, just like all other areas, we saw, given that the unit is electronics or machine dependent, we started having garages of broken instruments for a few things, and we started spending a lot. First and foremost, even the electrification of the units were faulty, and they could blow off most of our equipment. So we came to the realization, and we had to have technical assistance to get biomedical engineer, one within the system, and then it was supported by another that was within DFID. So with that, he had a very clear terms of reference. So as it is now, we are proud that we have a national policy on the management and maintenance of our medical equipment through the support of this project. And of course, the manual for inspection and prevention of preventive maintenance, we've already discovered and done that. Basic troubleshooting, special care baby unit for the equipment. And then he has actually computerized inventory for all equipments within this system for maintenance and with maintenance plans, you know. So when we came, when we started, the local capacity was almost 0, but with his support now, at least every district that has this facility have got biomedical technicians. Yes, we know that their capacity is not yet up to speed to take care of these complex machines when they break down. So preventive maintenance is actually key. Of course, they can handle some few troubleshooting as we go. So we have these visits now, and most of them I have daily. Some of them have weekly inspections to ensure that action is taken before problems happen, you know. Next. For data, we have data reviews. First and foremost, we actually developed special registers because we are only starting now, and we have been having our data management system before. So we developed registers. We've developed inpatient forms. We've developed other indicators, newborn indicators, and which we've already incorporated in the DHIS. And we have monthly reporting using the standard formats that we have designed with our partners. And what we do is we have joint quarterly supervision of all these areas, the SCBUs, the maternity units, the pharmacies, and all other areas within the hospital. And this is joint from Ministry of Health, from our partners, and even districts, and even from other SCBUs, somebody join always. And of course, our review meetings are quarterly, wherein we go from one SCBU to, this is done on a quarterly basis. Of course, we also have the PDSR review meetings that we do to ensure that at least protocols are followed and things are happening. Next. So some of the key enablers that we see why we are scaling up, first and foremost, is the political will that is there, and with the aim of trying to really impact on our under 5 infants and neonatal mortality. So we have that drive now. I can call it a march in order, which we are trying. And of course, the process is fully inclusive, with Ministry of Health and Sanitation taking the lead and ownership, supported by our partners. Of course, we've developed the packages that we've developed, the documents we've done, the needs assessment forms, the equipment list that we have, the procurement processes that we have. These are all things that are helping us. Of course, and then even the local facilities at district level are in fully involved throughout the process, from assessment to keeping the area functional as we go, you know. Of course, and then the meetings, the frequent meetings, the review meetings, the supervisions that we do. And then, of course, we try to really brainstorm the joint supportive supervision, the on-the-job trainings, the QI processes are actually things that are helping us to do some few things. Of course, we are having continuous supply of drugs and other medical equipment as we go, and UNICEF is helping, ministry is helping with that. Next slide. Despite all this, we have challenges, and I will just give you, there are many, but I will give you key big ones. Electricity, as you saw it, is challenging, and we need to find ways. Of course, last week I engaged the Minister of Energy, and we are now in the process of solarizing, especially the key units in all these hospitals. For example, the SCBU, the labor rooms, the theaters, the laboratory and the likes. We've just signed that. The new minister is pushing for that. We hope that project will start, maybe start sometime next year, so that at least by the time we go mid next year or at the end of the year, we'll be able to overcome some of these challenges. Of course, human resource is a challenge, both in quantity, of course, and quality. We do not have enough pediatricians in country. Of course, we've started a postgraduate training programs. Hopefully in the next few years, we'll be able to surmount challenges like this. Of course, the scheme of service have career pathways now for all this cadre of staff that we need. Maintenance will still be a challenge because of the type of the cadre. We only have technicians. We hope as we go, we'll be having real engineers to really overlook some of our things. Of course, sustainability is a problem because it's capital intensive. Drugs has to be there always, and the type of drugs, and then of course the maintenance. Next slide. So the way forward, what we have done, is a way forward. We have subjected all our staff to a training program, you know, using our appreciative inquiry with technical sessions, because with the aim of trying to improve their attitude and the way they behavior towards the job and the way they do things. Of course, we are emphasizing on quality and interestingly, within the directorate, we have the quality program that works hand in glove and is always part of our monitoring and supervisory visits. We use the PDSA circle as we go. we are strengthening, we need to strengthen the client-centered care. We improve maternal care because some even the mortality in the SCBUs, birth asphyxia is still very, very high, and with sepsis before you can have even the prematurity. So we need to really continue to focus on the maternal care from ANC to delivery, you know, and then of course we strengthen the perinatal death surveillance and response. We want to improve our electronics, our data management system by trying to go digital to establish electronics recordings. And then we'll have to strengthen the preventive and corrective maintenance system, the supply chain, be it hospital, cold chain, be it electricity, be it drug supply. We need to strengthen that one, of course, and then we enhance the continuum of care by linking SCBU and maternal and newborn care at the PHUs. In few districts, 4 of those districts, we've already started doing that, but as we go, time goes, as we expand, we'll also be going into other districts to ensure that that linkage from the periphery to the district hospitals is done. Next slide. Yes, so these are some of the things since we started 2017, some of the documents, the things we've done. Of course, our ENAP was developed and is already here, which we can share. You know, we've done some national standard operating procedures for management of small and sick newborns. We've developed that. We've done job aids for the management. We've done, we drafted the training manuals, facilitators guidelines, and logbooks for post-basic neonatal nursing training, the PDSA training manual, the reporting forms, and most of the SOPs and the tools that we need, we've actually done, and now we've computerized the inventory process to ensure that we keep track of what is happening and the functionality of those things. Next slide. So I want to thank you very much. I hope I did not take too much time.
Thank you so much, Dr. Ken. Very clear and very informative presentation. Again, we have a lot to learn from Sierra Leone. It's very nice to see that you have managed to engage the first lady. Sorry, Ibrahim, can you? Sorry, Ibrahim. Yeah. Okay. So I mean, it's really very good that you have engaged the first lady to champion this agenda to establish special newborn care units in all districts, and you have seen already very clear progress. And it is also worth noting government is really taking more responsibility to support staff, almost 80%, to ensure sustainability and ownership. And you have also tried to address the equipment management issues by assigning one biomedical technician in every district where you have established special neonatal care units. This is very encouraging. We look forward to learn more. So in the interest of time, let's move to the next and the last presentation from Uganda. May I call upon, I hope, Dr. Jessica Nsongwa, Commissioner of Family Health, is going to do the presentation. Over to you, please. If you are in this meeting, please introduce yourself and take the floor. Over to you.
Good afternoon, everybody. Dr. Jessica Nsongwa Sabiti. Uganda, I want to introduce my team. They could quickly introduce themselves here. Members from the USAID project, child health. I have colleagues from UNICEF Uganda, colleads from WHO, I have colleagues from the Ministry of Health, I have colleagues from Zambia Hospital, and a few others who also joined us today as part of this presentation. So can I have my presentation? Okay. So this afternoon, we are going to share with you our experience with a sick and small newborn in Uganda. Next slide. So this is our outline. Basically, we'll give you some background information. We'll tell you where we are, and then we'll enumerate the package, the status, and then we shall share with you some of the facilitating factors and challenges, and then maybe some of the available resources we have developed which we will share for learning purposes. Next slide. Yeah, so I'll begin with some data on newborn. And in Uganda today, we have a total population of 42 million people as of the census, and then we are expected live births annually. About 2 million babies are born every year in this country, and we have about 150 districts in this country. Our institutional delivery rate is around 73. It has increased by 28% since 16-17. Our perinatal death has reduced by 10% from, again, 16-17 to date. And our institutional perinatal newborn mortality stands at 30%, a reduction of 30%, and stands at 20 per 1,000 live births. The fresh stillbirth rate also has reduced by 25% and stands at 7.6 per 1,000 live births, and the mass-rated stillbirth rate is also 7.5 per 1,000 live birth, and has also reduced by about 32%. Our early neonatal mortality rate is at 5 per 1,000 live births, and was also reduced by 38%. And our early newborn neonatal mortality deaths have also reduced by 17.5%. So basically, we are seeing some improvement in the last few years, 5 years, and this can be attributed to some of the intensified interventions, which probably I'll talk about briefly. Next slide. So this is our organizational structure. We have 3 levels of newborn care. We have the highest level, level 3, where we have our NICUs, and basically we have 5 of these, basically located in Kampala, and then we have a few in the regional referral hospitals. We have about 14 regional referral hospitals and 162 general hospitals, where we have a spectrum of special care units and some newborn care units. And then at the lower level, we have corners, and we have, again here, we are talking about 222 health center floors. And here they deliver the basic essential package for maternal newborn care. The next levels do CMOC, and our first level cesarean section is at level 4. And then we have all the hospitals, of course, doing surgery. Next slide. This slide again shows the admission rates for different conditions. The first column, of course, is the condition. Then we have the cases and deaths and the case fatality rate. But also we are comparing 2 years, this year and last year. And maybe just to mention that our biggest cause of mortality basically is pneumonia, as you can see, and meningitis. And the trends have reduced to some extent, although overall, some different conditions have improved, but overall, the condition has remained the same. Sepsis, as you can see, also stands at around 5%. The case fatality rate is around 5% and has remained the same over the 2 years. Next slide. Okay, availability of CPAP and some information on staff skills and knowledge. And as you can see, these are our referral hospitals I mentioned earlier on, and you can see that some referral hospitals don't have CPAP, although a few do have, and then also some of them are not functional, as you can see in the second column, the third column. And in terms of staffing, we have about 75 health workers who manage these areas, and only 40% of them can be regarded as trained or skilled in using CPAP. So you can see that we have a lot of missed opportunities because of people not being trained, but most importantly, most of our infrastructure requirements are still needing. Next slide. So this is about policy formulation, planning, and budgeting. We have a national plan for scale up of the newborn care, which we developed, and basically we developed a framework for implementation. And this is part of the broader sharpened plan for RMNCH. We have a community component, which is part of the ICCM, where we do home visits, but also the health, the sick newborns are assessed and referred to the facility. In terms of budgeting for the different components of the small sick newborn, we have a budget for the home visit, which is part of the ICCM, like I mentioned, but also we have budgets for special care units we have been constructing. And this year we have constructed 25 newborn care units, which are now being functionalized in terms of equipment and training health workers. The standard unit cost for establishing our newborn care units, but we are hoping to work on it. Our maintenance and operational costs through the existing system, primary care budget, but also have some biomedical engineers who work at the grassroots, and they are also salaried. Our funds basically come from the national level, especially at referral hospital, and the districts mostly have a decentralized budget, so they receive their money from the local government. But we also have additional funding from GFF. We're doing performance-based financing, but also we have several partners who are funding different components of the small sick newborn package. Next slide. So our bed capacity at different levels, we have various arrangements, but we don't have specific standards for bed space, which is reserved for newborns. And this is an area we have been working on. We have just developed guidelines for a national referral hospital, and we are hoping to cascade these guidelines down. The floor plans, we have existing infrastructure plans for health center 2s and 3s and 4. And more recently, we have added the newborn units on the infrastructure. So the units which have been built this year and last year now have a newborn care unit attached to them, most times next to the maternity ward. The newborn resuscitation, KMC, special newborn care units and health center 4s, we are also available in some facilities, maybe not all, and services are provided here. And we have trained health workers to manage these areas. In terms of services, ancillary services, we have things like WASH, infection prevention and control. We're doing triage, and we have a reception area in a number of these places, including a counseling area. We have a maternity ward, and in some places we have breastfeeding support areas and counseling rooms, but not all of them. Most of the mothers breastfeed on the ward, or they come to the newborn special care units. We also have laboratory support, pediatric surgery in some of the referral hospitals, and most hospitals have radiological services, and there's a follow-up clinic in the OPD for newborns, which is done mostly on a specific day of the week, but this is not occurring in all levels. The newborn care is closely linked to the maternity care, both infrastructure-wise, but also in terms of health workers managing the different areas. Next slide. In terms of procurement, deployment, and maintenance of equipment, we have specifications have been developed for equipment, a national equipment list and supplies list, and it defines the different equipment for the different levels. CPAP, however, is not part of the standards of equipment. Although we have been promoting it, we don't have it in the essential equipment list, which was developed in 2019. Current procurement mechanisms are mostly centralized, and for the National Referral Hospital, they can order, but for the lower facilities, we do a push system. So equipment is procured and delivered to them, and we supply the equipment based on their budgets. In terms of repair and maintenance, we have regional workshops for repair of most of these facility equipment in the hospital. The biggest problem with these workshops is that they are basically underfunded. They have inadequate funding, and this budget has been reducing over the years. In terms of inventory management and replacement, we have inventories which are kept at all levels for equipment, including specifying which rooms should have which equipment. And again, this is also, these are some of the things also we are assessing and as result areas for the performance-based financing program we are running for maternal mortality. Next slide. Yeah, human resource-wise and needs for the small sick newborn. We have staffing norms, and we have just recently actually updated our staffing norms. And the human resource wage bill is separate from other cost centers. It's been increasing over the years, and it's ring-fenced. We've also been upgrading the training, and we've introduced a fellowship program for newborn health, and we are providing scholarships for students using the World Bank GFF money. We have a training package, and these health workers are training for about 2 years, and this is an in-service training package. But we have also revised the pre-service training package. This was done 2-3 years ago. Next slide. In terms of data system, we have different data systems which reflect, but most of them are paper-based. But we also have the DHIS tool, and in all these systems, we have data for small sick newborns. We have actually a book on indicators for newborn, which we were able to negotiate, and this is part of the HMIS. But also more recently, we have QI indicators, and we've managed to negotiate to include some of these indicators. And they are used also for the maternal, for the death reviews and as part of the QI processes. Next slide. The key indicators that are being tracked for monitoring performance are listed there. You can see most of them are output-based indicators. We have fewer process indicators, and these are mostly picked during supervision. Next slide. The referral systems, we have a referral system linking the community and the health facility, but this is mostly done by individual patients. Although we have a referral system and referral guidelines, and the community health workers have been trained. Our first referral facility is a health center too. It's not a delivery unit, but sick patients can be seen there. And we are slowly introducing PSPI, rolling out PSPI in the country. And we don't have special transfer mechanism for KMC babies who are in KMC, and most mothers are guided to just do KMC as they transfer these babies. And we have an ambulance system, which is still in it's not very advanced, but during COVID, there's been a lot of enhancement for this ambulance system. Next slide. So mechanism for post-discharge and follow-up. The current policy for screening at discharge, we have a discharge form and discharge counseling process in the health facilities, and these patients come up to the newborn OPD clinic for follow-up. There are also specific numbers of visits which are promoted for these babies, especially those who are very low birth weight or who have been sick. The VHTs have also been trained to do home visits, postnatal home visits on day 1, 3, and 5. And as I said earlier,
Sorry, please mute.
Next slide.
Go ahead.
Yeah. So in terms of incorporation of family-centered care as part of the small and sick newborn, we have been pushing for some work on through the nurturing care framework, but also we have the baby-friendly hospital initiatives, which also push for some of the rights and trying to make sure that the family is participating and we have autonomy. They participate and they make decisions, including having a companion during delivery. We also have some Gupta indicators. Actually, right now we are piloting some indicators for respectful maternal newborn care, and we are hoping to see the experience after this audit, which is ongoing. Next slide. Efforts to perform more effective communication and meaningful participation. Again, this is being done around using the rights-based approach and respectful maternal care approach. And here, again, as I said earlier on, these have been included IMCI and KMC training and the quality of care standards training. These are key elements in this training, and most health workers are taken through this process. Next slide. So what have been our key enablers in the process of trying to improve newborn care and especially small sick newborns? The first issue is a strong leadership and partnership and coordination at both national and regional level. We have structures at the national level. We have the National Newborn Steering Committee, but also we have some special subcommittees. The committee which is focusing on quality of care, the committee which is looking at equipment and commodities. So these coordination committees, which also link with the districts, have been very instrumental. We have also tried to leverage existing community structures, especially for the community health workers and community dialogue activities. We also have a government-led innovative program on performance-based financing, which also has been very useful. And as I said earlier on, we have a mentorship program, national mentorship program we are rolling out, which also includes a community. Next slide. So we've had several challenges in the process, and one of them, I think one of the most important challenge concerns the human resource, both in terms of numbers and capacity, and we're trying to do some task shifting. We have also had issues to do with not having a specified cadre for newborn care, both in the training, the in-service training, but we are hoping that the 2-year fellowship program will be very instrumental in helping us to build a pool of master trainers and supervisors. Funding also has been relatively low. We have also the mechanism to track and monitor coverage, including quality of care, also remain a challenge, although this is improving over time. And in the performance-based financing program, recently we pushed to include quality of care indicators and some included newborn care, but also the issue of commodity equipment. And this ranges from being able to procure and order the equipment, but also being able to standardize the equipment, especially we get some equipment from donors, and sometimes the specifications are not very standardized. Next slide. Some of the resources would like to share, and you'll allow me to add on a few included here, but I also wanted to make sure that we have a program, a digitalized program, which follows up 6 more newborns with high risk to be able to make sure that they don't die after discharge. The program is.
I don't have a guitar, there's a cello.
A maternal child health passport, handheld records. And we are also doing some program on, of course, PSBI is also included, but not in this time, but we have finalized our PSBI guidelines. So some of the guidelines here we have, which we can share. We also have a core indicator of indicators for newborn, which we have been able to include in our HMIS, and they also include WASH in the health facility. And right now we are working on the indicators and standards for respectful maternal care, and we're actually doing the pilot right now, and hopefully we should be able to share some of these this information. Thank you very much.
Thank you very much, Dr. Jessica, for a very clear and very informative presentation. Colleagues, this has been a very interesting day to share experiences, but we are unfortunately behind time. We are short of time by about over 40 minutes. So I can see it will be late for colleagues on the eastern side of the world. So maybe I would like to ask all the speakers to be available tomorrow morning when we start day 2. We can spend about 10 minutes to respond to the key questions that has been in the chat box for the 4 presentations. But if we wish to continue, we can entertain those questions, but I feel we are very much behind time. We were not able to stop the presentations because all of them were very exciting, very rich, very informative presentations. So I would like to propose to start tomorrow on time and request the speakers to be available to respond to a few questions before we proceed with the agenda of day 2. And we'll compile all the questions and the comments in the chat box and make them available to all of you. Is that a reasonable proposal?
Yes.
Yes, Dr. Tashoma, yes. Thank you.
Okay, thank you very much. Thank you from Secretariat, Gagan, Rajiv. Thank you so much. So we'll meet tomorrow.
Yeah, thanks everyone. Thank you very much.
1 p.m. Geneva time. Thank you so much.